Good morning, everyone. My name is Dr. Helen Brotherton. I'm the ICHG convener, and I'm delighted to welcome you to this year's ICHG Winter Meeting. So you're welcome, and we have a fantastic range of speakers today, and also attendees from over 20 countries across the world. So this is truly a global meeting of like minds, and we're really looking forward to rich discussions and hearing from people working on the front line about what is working to meet the SDGs in their particular area. So as we know, there's only 5 years left to meet the SDGs till 2030. A lot of progress has been made, but there are still key priorities, and we'll be thinking about those and discussing those throughout the day. So just some housekeeping, first of all. So we're using the MEDAL platform. If anybody has any issues, technical issues, then please contact the tech team who are at support@medal.uk. We have some network sessions as part of the programme, and you can access those through the breakout sessions on the left tab of your screen. If you have any questions for the speakers, we really want this to be a rich discussion. So please feel free to post questions in the chat, in the messages, and then at most of the plenary sessions, we will have a panel discussion where we'll try and answer your questions. We're keen to get as broad reach as possible. So if you're active on social media, please follow us. And these are the hashtags that we'd like to use for the day that you can see on the screen. So we really have a packed day. Very excited to hear from some of our fantastic speakers. And please get involved. It's wonderful to have you. So we're starting, our first keynote is by Professor Joy Lawn. So I'd like to invite Joy to the stage. Welcome, Joy.
Hello, Helen. Such a privilege to be here.
So we're delighted to have Joy open the day. So Joy's a professor of perinatal epidemiology, also a paediatrician, Ugandan-born paediatrician, who has really been instrumental in pushing forward the neonatal health agenda over the last 20 years. And we're delighted that Joy will give us an overview around the SDG targets called pessimism, optimism, or evidence-based activism. Over to you, Joy.
And I'm trying to find some optimism to get the screen to work.
Would you like us to share your slides for you?
I've slightly adjusted them, so are you now seeing?
Yes.
Okay, my optimism worked. Firstly, thank you so much to the ICHG for being a voice for children. Thank you, Helen, for your leadership and thoughtfulness, and particularly raising your voice on very important issues of our day. And my job here is to set the scene. And I think if we look at the news, we feel overwhelmed with pessimism, both for the world and also for the future of children. I was once told that with a name called Joy, I was doomed to be optimistic. And sometimes we think optimism is not realism. What I want to bring us to, and I believe that we as professionals who stand for children and families need to have the right evidence to then lead to evidence-based activism. So not just advocacy that is noise. And so if we think about that, let's start from where each one of us started. So we each entered the world, apparently the same, but definitely not equal. So the world's births have peaked several years ago at 145 million a year, and every continent is now reducing with the exception of Africa. And among those 132 million births, we entered the same but not equal. So in high-income countries, and the UK, for perspective, has about 0.6 million births, about 10 million in high-income countries. and many on the line will be those who look after children or newborns in a higher income country setting. And this is where most of the data and the evidence are based. But the world is changing. So the countries are graduating into being upper middle income countries, most of Latin America and Southeast Asia, 45 million births. And in this context, actually over-medicalization is a huge challenge. So in Brazil, more than half of births are C-sections. In China, the fastest reducing neonatal mortality rate in the world, a lot of that has been achieved by very medicalized care where often families aren't available or unable to be there. But still, most of the world's children enter in low and middle income countries. There's been a massive shift in the last 10 years to births in facilities and being able to have access for care in facilities. But there are still 30 million births at home. It was 60 million about 10 years ago. And those 30 million births are the poorest and the most vulnerable. And they're quite localized. Northern Nigeria, rural Ethiopia, parts of India and Pakistan. And in each of these places, we need to use the evidence and the data that we have to make change, but also to have that change lead to sustainable change so that we move from home births to births in facilities to better births to family-centered care. And then in high-income countries, while we produce a lot of the evidence, we also need to learn how to bring families in, how to think about thriving. And yet, sadly, there is also backsliding. So there are countries that have gone from being upper middle income countries to now having challenges with care that cannot be provided in hospitals being bombed. We see Syria, we see Gaza, we see challenges in forgotten crises like Sudan. So across the world that you're born into determines your survival and your chances of thriving. But in each of these places, we can and we must change what happens, and that is possible to do. And to do that, we also need better data because those who are highest risk often have the least data, the inverse data law. So if we think about that birthday, your birthday for both women who are giving birth and or people who are giving birth and for babies is the highest risk day. 1 million babies dying on their first day, their only day, the steepest part of your survival curve, not just in childhood, but for your whole life. And also stillbirths on that same time period, often lost, but utterly critical and count for families, and maternal deaths. So this steep curve for a pessimist is the greatest risk of death and disability. For us who want to use data, it's our opportunity for a major return on investment. And we need to start flipping the narrative. It's not just about a moral imperative, which is very hard to make the case on now and will be harder in the next few years, especially in the US, where the greatest health funding comes from for global health. So that major return on investment is critical. And if you're on this call and you're starting out on your career, remember the two most important days in your life, the day you're born, the day you find out why, and make your choices based on what can make the biggest difference, not just what everybody else is doing. So I want to move on to our topic on the Sustainable Development Goals, and to start with optimism. So the Millennium Development Goals from 2000 to 2015 have been called one of the world's greatest collaborative success stories. There were 8 targets, probably set by 5 white men in a room in New York, mainly health economists. And 3 of those 8 focused on women and children and health. And they really led to change. Now we have the Sustainable Development Goals. Again, fantastic that almost every country in the world has signed on. A totally different story of collaborative process in setting the goals, with low and middle income countries, particularly from Latin America, leading the charge. Like all good committees, ended up with very many more targets. So 17 sustainable development goals and a scary 169 targets. I'm not going to go through all of those to see if we're on track. and within the health target, 13. So 3.1 is for maternal and 3.2 is for child and newborn, still at the heart of what is done, but much more complicated. Many more targets, only one for health, which shows we cannot afford to compete with each other. We cannot compete surviving with thriving women with children. We need to join up, and we also need to join up beyond the health sector. So with climate, with nutrition, and I salute you for the programme later today, where you will be having more of these other topics. But we still have an increasing problem with polycrisis, which are affecting and have really amplified in the last few years, whether it's COVID, which we all like to forget, climate, cost of living crisis. So many C's in a polycrisis. So where are we now? Helen has said we have 5 years to go. And at this point, with 5 years to go, we still have almost 300,000 women dying, really preventable deaths from hemorrhage and conditions that really shouldn't be killing women. We now measure child deaths, not just to the age of 5, because for those of you who have kids, and most of you work with kids, you don't just want your child to survive to 5. So we measure to 20. And all the UN reports, so they come out every year. Remember, the numbers do change every year, so you have to look at the latest report. This is the latest UN IGMI report. And from the age of 1 month to 20 years, 3.5 million children dying. It's still stacked to earlier, so the under 5, but that missing middle, the 5 to 10, is also critical, and adolescence is also critical. We shouldn't compete them with each other. But really driving the mortality now is that first month of life and even that first day of life, with 1 million on day 1. And this 2.3 million for neonatal deaths, the first 4 weeks, has been a flat line for the last couple of years at 2.3 million. So utterly critical to do more. And it isn't that we've failed when we tried, we still haven't invested. So a lot of opportunity for return on investment. And still stillborn on the global agenda are stillbirths, almost 2 million. And here, these are the global numbers we work on for the last 3 months of pregnancy, the last trimester. So, of course, many high-income countries count from around 22 weeks, the UK from 23 weeks. So it would be more if we counted that, but the data are more unreliable under 28 weeks. So this huge number together is 8 million deaths of women and children. And we should stand together for those. We should make sure these are more commonly in the news. And for example, the UK government has very little focus on this now. This is an area where both the Royal College and the International Child Health Group could call out the UK to spend more. And the geography that carries the greatest weight is Africa, condensing in on Africa and condensing in on the time of birth when babies are the most vulnerable. If we zoom in on the geography, so the geography of Africa, and has someone who was born in Africa and who spends most of my pediatric clinical care and research time in Africa, this should be unacceptable to us. So currently 15% of the world's population, about half of the burden. But unless trajectories change, both for births and for risk of death, Africa as a continent will hold 70% of global maternal newborn deaths and stillbirths by the time of the end of the SDGs, so only 5 years from now. So this is an area that needs a special calling out and partnership across Africa to change. And there's a linked gap here, because only 2% of the published research has an African author. And I'd encourage you to look at this paper stuck in the middle, which also shows that there are inequalities in how that authorship is done. And this is something that all of us, and I really hope the ICHG will continue your voice on decolonizing global health and equity. And thank you for making access open to this meeting to low and middle income countries. And to say that sounds big, but there are ways we can all change it. So just a year ago, this week, this series of papers were launched on African-led implementation learning on neonatal care. And the author team deliberately was enabling Africans, female authors, and first-time authors. So we can make choices in how we do that. The good news is that there is leadership from Africa for change. So across Africa, for example, the one female president that there is in Tanzania is really speaking up on women's and children's and newborn health. This 6 years to the deadline World Health Assembly resolution that garnered major traction this May in Geneva was led from Africa, actually by Somalia, which is a really wonderful salute to them. And I'd encourage you to look at the 6 actions there to take forward, which are very practical about investment and implementation and data. I want to zoom in on the child, because this is the child health group. So this is the target. The good news is that we still have a target. The double good news is we have a specific one for newborns, which was added from our Answer Every Newborn series and the Every Newborn Action Plan. So 5 years from now, the national target would be under 5 mortality rate of 25 or less and a neonatal mortality rate of 12 or less in each country. So this absolute target, of course, is harder for those who start with a high mortality compared to a relative target. And so the good news is, while many countries have set targets, many countries are actively acting on them. There are 64 countries off track for the neonatal, about 50 for the child. And a similar number, about 50 for the stillbirth. And most of these countries are in Africa or are conflict affected or both. So how fast do we need to go? For those of you who are runners, we're setting out on a 5-year run. What's our speed? What do we need to do? So this is the rates of change required for under 5 mortality on the left-hand side and for neonatal mortality. So the current rate of change for under 5 mortality across Africa is 2.9. The neonatal is about half that, 1.7. So countries need to go between 2 and 10-fold faster. Nigeria, 10-fold faster for neonatal mortality rate. And Nigeria is currently number 1 in Africa for child deaths and has actually increased in the number of neonatal deaths over the last 10 years. So that's how fast we need to do. If you want to run, look at who's running fastest. So if we look at the remarkable progress over the last decade and a half for HIV and AIDS, it is an amazing example to learn from. So it went from around 1 million deaths to now about 21,000 in the latest data. There's been fantastic success with mother-to-child transmission, led from South Africa, despite political opposition. And I was there and know many of the people who brought the court case, actually, to make sure that antiretroviral was provided by the government. So that was an example of something that needed to change in costs, needed political change, needed systems change, needed better data. And it was able to be done. And in fact, we did this even faster for COVID. So I want to say that we can do this. It's about the decision to do so. It's about the level of ambition that our leadership has. And maybe one of our problems as pediatricians and people who work on newborn health is we're just too nice. So we have data here to show that there are things that can change. And for certain conditions, they have changed. Now, of course, AIDS also kills adult men. So for things that selectively kill babies or children, we have to find ways to make that case. So if we move forward into which causes to focus on. So Hans Rosling, one of the famous communicators of data, said we often live in data from the past. I would say a lot of people live in a pie from the past for causes of child death. So this is the most recent pie chart for causes of child death. If you were to ask the average person on the street, either in a low and middle income country or a high income country, they would normally say that infections is the main cause. It's actually down to 32%. And of course, there are still really unacceptable deaths there. Now we have much better solutions for malaria, including vaccines coming, bed nets and so on. We have new vaccines, meningitis vaccines being rolled out, with heroic new changes. Really shocking that we still have deaths from diarrhea. So all of these shouldn't be happening. But for us to push forward in the next 5 years, we won't succeed if what we continue to do is the same things for those 32%. We need to look at the half that are now due to neonatal conditions. So 48% in the neonatal period, and at least 2% from neonatal causes that happen after that first 28 days. And of course, the post-neonatal deaths from neonatal causes are much higher in countries with more aggressive neonatal intensive care. And then not to forget the non-communicable diseases coming up. So actually congenital conditions now cause as many deaths as pneumonia does, if you look at the congenital conditions together here. So really important for us to think about and understand and future project and really act on what the data are and what the direction of travel is. So zooming in more on preterm birth, this as a direct cause, so not just among babies who are born preterm, this is the top cause of child deaths. And then if you go to the global burden of disease, in every region, this is in the top 3. So 7.3% of all disability adjusted life years, so all deaths and disability for all your lifespan is due to preterm. So this is utterly critical. And, it's not that we want less money to be spent on other things, but money should be spent proportionate both to burden and to potential for impact. So where is the money? This is a paper we published last year in Lancet Global Health to hold funders accountable. So RMNCH, so reproductive, maternal, newborn and child health. The good news is that there still is considerable donor funding. This leveled off a bit during 2020, and the newer data suggests that post-COVID it hasn't fully picked up, but this is still a substantial amount of money, almost 16 billion a year. So the first thing to do is to say, well, spend that money well. Of course, it would be better if there was more money, and domestic money from low and middle income country governments is also critical, but a little harder to track. And if we look at this, more than half of the money is actually spent on child health. To note that within that, about 2/3 of that money is spent via funds. So via Gavi for vaccines, via Global Fund. So a lot of that money is coming in slightly more vertically. So how do we use that to also build health systems so we can care for sick children, as well as doing these other preventive things that are important? Both are important. And if we look at this little yellow jaundice band, that is any donor funding that has the word newborn in it. So that is about 10% has the word newborn in. Just remember, it's half of the deaths. But only 1% has an actual intervention. In fact, the most common way newborns are mentioned is in the phrase maternal, newborn and child health. So more a philosophy. So holding donors accountable for actual spend and potential impact is critical. And shockingly, almost unmeasurably small number even mention stillbirths or any other word to do with stillbirths. So despite the potential impact being similar, the numbers being similar is not on the donor agenda, largely because we don't talk about it, which is to do with stigma and power and gender as well. So moving forward to zoom in on small babies. So small babies are a big problem with deaths, with disability, and also with small for gestational age, leading to about half of lifetime stunting. So utterly critical part of the lifespan, as well as the later non-communicable disease epidemic. So for South Asia, as well as looking after diabetes and hypertension, turning off the tap by better health of girls and maternal health would be utterly critical. And within this horrible flashing thing that you can see on the right here, there's a flat line bar chart, which is the flat line here for preterm birth rates in every region around the world. So this was our estimates that were published in the Lancet 200-year version last year, the 200-year issue. So while we need to find ways to move better on prevention, the main message here is that the world has primarily reduced neonatal deaths and therefore child deaths by better care for these babies, and we need to do much better on the care angle. So in some ways, this is like the antiretroviral story. We have a survival gap around the world between those who get care and those who don't. So a baby born in a neonatal unit in Nottingham, where I used to be a neonatologist, would have at 28 weeks would have a survival rate, a mortality rate of less than 5%. And in high income countries, that would be more like 95%. So this gap of 90-10 is rounded, but is a major gap. And just like we did for antiretrovirals, where we market shaped to reduce the price, we advocated, we went to courts, we need to do better to make sure that this survival gap is closed. And the positive news here is it would save 750,000 lives a year. It would allow many countries to get on track. But to do this, a shift needs to happen where we don't just have teaching hospitals in the capital, but districts in each country in Africa and across South Asia each have a functional neonatal care unit. And so excited to say that that is changing. So this was just 2 weeks ago, World Prematurity Day in Uganda. And the Uganda government deliberately picked a district hospital that was overperforming with a really impressive neonatal unit. In fact, a baby who was 25 weeks gestation and doing well. So picking out those who are doing well and paying attention to them, bringing parent groups, pediatricians and governments and getting the media on it. So to save this vulnerable newborn, we need systems change. It's not like we can just do one thing. So many of you will have seen a preterm baby, but often I'm speaking to policymakers and they haven't, and we assume too much knowledge. So this is Chikonjetso. He's 1 day old, 28-weeker, born in Malawi. He's got an improvised CPAP device. Of course, it would be much better to have a better, safer one with safe oxygen. But he's alive because people are saying, we're going to do something different. But to make him survive, but also thrive and enable that chance for others, we need to think not just about the ward level, but systems change. How do we change the whole pipeline for technologies and have biomedical engineers that are part of the system? How do we change the cost? How do we change data systems so we're measuring the right things, both at the time, but also for long-term outcomes? How do we look at out-of-pocket expenditure that's catastrophic in some countries, maybe especially Nigeria has the highest in the world? And how do we do targeted research on many fronts? So first of all, a very important principle, and this is whether it's any part of child health, but I want to take the illustrative example from newborn health, is that we keep the package as small as is possible. So this is the package that we're scaling up for small and sick newborn care across district hospitals around the world with WHO and many partners. And here we have, I'm not going to go through it in detail, but the core things that are needed. So it's more than one thing. It's not like just bringing in a vaccine. But on the other hand, if we bring in everything into this package, so for example, in a country I was in recently, drug companies have been lobbying the government to add surfactant. If we add surfactant, which costs as much as it would cost to care for maybe 10 babies in a district hospital, maybe one baby gets that in a teaching hospital centrally, and you're depriving care elsewhere. So need to think very carefully about what is being done. Because all of us want to see Chikonjetso, who you saw a couple of slides ago, and this means the conqueror in Chichewe, want to see him survive and thrive. And I know that Tracy and others will be talking to you later about that. So to move forward faster in the next 5 years, we need both money investment and implementation, but also better innovative research, and especially research that is at this end of the pipeline on the right, the delivery and implementation research. So we need all types. If we don't have the discovery science, the development science, we won't have new interventions. We need new antibiotics coming down the pipeline. We need better diagnostics for many things, for example, neonatal sepsis. We do need better innovation, but we have many innovations that we're not delivering at the moment. So we shouldn't say don't fund the other things, but we definitely need more funding on embedded implementation research for child health at all levels, at home, in primary healthcare and in hospitals. And Helen started by saying we're a group of like minds here. I hope we also are on like minds in a different way. I hope we have a common purpose, but we also bring different disciplines and perspectives, because to get better results for the world's biggest problems, and particularly for the world's most vulnerable, we have to get beyond our bubbles, mix with other people and have new ideas. I just have one slide on this, but I think such an important example, kangaroo mother care, and Helen has done both her PhD and many papers on this in the Gambia. But over the last decades, KMC went from being, in many ways, a solution for poor people, not having care, trying to make it work in Colombia. And I was just recently with the Colombia 30-year KMC meeting. And then shifting from that to being how we scale it up in Africa, but still without mortality evidence. And then mortality evidence for kangaroo mother care for stable babies, and then increasing evidence for kangaroo mother care for unstable babies with new trials. It's actually high-income countries that are scaling this up. And the UK could be going faster. So in Scandinavian countries, there are units being rebuilt. I was examining a PhD in Karolinska last year, fantastic Swedish neonatologist, and just amazing to see what is there. So thinking about how that works, and you can't drop what's happening in Karolinska into rural Uganda. How do we make that work? So really critical to contextualize and have active implementation research to take forward important guidelines which bring a pivot. And this pivot, whether you're thinking of newborn care or anything else, putting the woman and empowering her at the center, not as an intervention for her baby, but respecting her, means that you have to have showers and places where she can also care for herself. So this trial that we just closed in Uganda and published in Lancet this year shows that if you do get higher dose of kangaroo mother care, more than 12 hours per day, you start early enough, you do have massive impact. But the between arm difference was seen but not significant, and very consistent across Africa at about 14% reduction in mortality for these babies. But to make that work, we need to spend more. So I just want to give you a couple of slides on accountability for research funding. So we're saying that research, and especially implementation research, can help drive faster change. And when we think, for example, back to COVID, we would all still be on lockdowns if we hadn't had the rapid amount of ambition, money and change that led to diagnostics and vaccines. We need to be able to bring that to other challenges. So if you don't know this database, Dimensions is the world's biggest research funding database. It scrapes everything up off the internet that says it's research. So it has 7 million grants. And across those grants probably captures most, except for those who don't put on the internet. So pharmaceutical companies maybe don't, but all languages. And it's been used a couple of times, but not very much, to assess accountability for research funding. So we did this paper, which was published last year in Global Health, and actually led by a number of really fantastic pediatricians who I think are part of this group. So Eva, Priyesh, Libby, and a number of others. And they did it on the side, and it was a fantastic piece of work. And so the top finding out of this, much to our surprise, is that around $577 million are spent each year worldwide on research mentioning newborns and stillbirths. But very depressingly, only 7% of this is bad news or pessimism, goes to low and middle income countries, even though they have 90% of the burden, 98% of the burden. An optimistic note in that is that the BRICS countries, so Brazil, Russia, India, China, and South Africa, have all increased by around threefold the amount of money they are spending themselves on their own research on these topics. But overall, the inequality is huge. And if we look at what it's spent on, so are people spending research money based on the burden? So the pie chart I showed you earlier. So if you think within neonatal conditions, number 1 is preterm. So that's number 2 here. That's at least reasonable. And neonatal infections is number 1 by quite a long way, actually. But stillbirth research gets very, very little funding, and actually gets very little research funding in high-income countries to high-income countries. So, for example, in the US, that has about 14,000 stillbirths a year, more than their infant deaths, there's very little money in hundreds of millions of dollars of NIH grants, which are primarily focused on the live-born baby. And then if we look at the research pipeline, so here we're saying, yes, we need all components of the research pipeline. We need the description, the discovery, the development, and the delivery. But here, the research funding is really heavily weighted to the first part. And it is the last part of that research pipeline that gets you a shorter timeline to impact. So really critical to shift this, and especially in low and middle income countries to shift this. So I guess good news that money is being spent, bad news in the inequalities, and also the power structure that is still with high income countries, and a big need to shift both the implementation research and the leadership to low and middle income countries. So I'd really ask all of you who are on this webinar, please do have your say about this. We have a Lancet Commission on Evidence-Based Implementation. And what we want to do is to combine these circles, implementation and research, so that the people who are doing the implementation are empowered to do the research. They're not overwhelmed by so many frameworks and complexity that is often put out there for implementation research. So please do this survey, have your say, and also use this map, which was just launched yesterday on the Newborn Toolkit. There's a webinar that you can watch with some early career researchers from Uganda talking about how they're using the map and looking at Uganda. So this takes the data from that paper that I just talked about, puts it into an interactive map, and you can click on a country, see how many research grants there are. So, for example, if you click on South Africa, which has the most research grants in Africa, followed after that by Uganda. And half of these are on neonatal infections. And I think that could be credited to a few wonderful people like Angela Dromowski, but actually very few on implementation research. So I encourage you, if you're based in Africa, if you're working with colleagues, link on what's happening already and use that to reshape. Importantly, we need to combine together and learn together and also link with governments. So it's such a privilege to be part of this Nest 360 Alliance, now working in these 5 countries that are half of Africa's newborn deaths, with the governments, with 22 organizations, mostly African research organizations. And we're working in by the middle of 2025, about 150 hospitals across all these sites, and placing a bundle of devices enabling local workers, enabling maintenance, and so on. But actually what we have found is it's the data that are foundational. So having data to track coverage and transform care is what is starting to pivot the mortality. And we're seeing across those facilities now, we've got facilities with between 10 and 55% reduction in mortality. So really critical. And within that, embedded how-to questions, how to increase KMC, do it earlier, do more hours, how to change coverage of respiratory support, how many nurses, how many devices do we need, and so on. And within that, also trying to fix some of these knotty problems. So in the past, often equipment is donated, drops from the sky and ends up in an equipment graveyard, sometimes hardly even switched on. So really critical that we think about that whole pipeline as a system and change it. And that we work jointly with biomedical engineers, and lots of learning from that. I would encourage you to look at the Newborn Toolkit if you're interested, and to make that sustainable, because whether we're pediatricians or neonatologists, we tend to love machines that go ping. And unless we have more biomedical engineers within hospitals that are the government people enabled to join this, and more African-led innovation and manufacture, it's not going to sustain. One of the things that I have learned just in a completely new, out of left field for me over the last couple of years is working with architects. So how do we really pivot infrastructure to be a foundation for care? If we sit in a tiny room that has no space and everything in tears, even the babies sometimes, it's really hard to expect we will change outcomes and have respect for women. So very important that we think intentionally about making the case for money. And this is a paper that we published with the government of Tanzania for their national scale-up plan for small and sick newborn care, and launched at World Prematurity Day last year with 1,700 people and the previous president of Tanzania, with just amazing leadership to then move forward into change. And they are empowered by having their own plan for how many districts need new units, what they're going to do, and for a gap of around 2,000 nurses that is critical. Otherwise, we will build and not provide care. So if we do that, we can really transform care. And that is so important for the families, for the children we care about, also for workers and also for nations. For all of you, please, I really encourage you to join us to help go faster together for newborn care if you're interested in the newborn part. And there are also other groups for child. And I want to finish with this message of optimism. So every woman, every newborn, everywhere. This woman has hope. She has fears. And this hospital is the hospital I was born in. My mother had an obstructed labour. She was taken in, and during the night, the woman in the bed next to her sadly passed away. And in the morning, they found somebody who could do a C-section for my mother, and she survived and I did. And my job, your job, is to make sure that that voice is up for everybody. That every woman, every baby, every child, everywhere gets someone to make a voice for them. And I'm just so happy to say that in a visit back there this July, the hospital is utterly transformed. So Africa is changing Africa. The Ugandan government has built this lovely new hospital with a great maternity unit and even a small newborn unit and a KMC poster. So the world is changing, and our job is to find the people who are changing it and back them and to go faster together. So what can individuals do? What can ICHG do? Well, first of all, do know your data. Don't live in the data from the past. It does change. Support ICHG. Get behind the team, Helen and the fantastic team that have put this on. Join other things that are working. Share. And then together, let's enable ICHG also to be a powerful voice, speaking to the UK government about funding, speaking up on the war in Gaza. So absolutely devastating, but utterly critical. And thank you for being a voice going to speak to the Prime Minister next week. So important. Together, we can change the world for every newborn and for every child and for every family. The question is, will we deliver, and will we do it fast enough in the next 5 years? Thank you.
Joy. Thank you so much. We have a slight echo. Okay. Joy, that was an absolutely wonderful tour de force, so inspiring, but also so sobering to hear again about the data and just especially the inequalities in the outcomes, in the funding, but then ending with a really positive note about actually how can we as individuals, as paediatricians, as child health allies, really try and advocate and impact for more funding, more action, more implementation research, particularly for newborn care. So really, and also thank you for your leadership in really driving forward the data, because you're absolutely right. Without data, it's so difficult to make any positive change. So we have one question in the chat, and I also had one question myself. So you highlight the funding inequalities for research. 7% of newborn health funding in LMICs. There are structural barriers within the funding structures for research, and it can feel difficult sometimes to try and break through those structures. So do you have any advice for people in the audience who maybe are putting grants together, or how can they try and break down some of those barriers and get funding?
Yeah, so important. And I think we need to think of that change on different levels, you know, what you can do as an individual. So in your choices. So for example, there are UKRI MRC partnership grants. And really delighted to say we've actually just been able to get one, and we deliberately picked to do it with the African Neonatal Association lead, and the at the top is an African neonatologist who actually hasn't published a dump truck of papers, but is a fantastic leader. So I think choosing to champion people like that and really push through so that they get opportunities is a quicker way to pivot things. I do think that ICHG can be a voice on this. Mm-hmm. So I would reflect that the MRC Global Health Board has a maternal newborn grant out, a child survival grant, and an adolescent grant. And actually those were shaped by a strategic review that we did and took to them a few years ago. So I'd really encourage people to look at those and think how to do those. And just so important that we make the effort to walk the talk in doing partnerships ourselves. So I think at the individual level, pick who you work with, walk with them, you know, take time to make that work. For the ICHG level, you know, speak out. And if we can help you do that, speak out to the funders. And I think especially speak out to FCDO. So David Lemmy there now. So, you know, we no longer have a UK Department of Aid. It's within the Foreign and Commonwealth Office. So, and then I actually took out a slide I had there on kind of examples for how to get started. But if you want to get started, you know, pick an answerable question, pick an answerable way to answer it, a doable way, you know, read, ask some other people, and get some data, because you're more likely to get a grant if you've got some data. And Helen, you did a fantastic job on that. I mean, I'm sure you can also speak to that. And I would say don't be scared to reach out and ask. That, you know, it's really, you know, all of us are on a journey.
Thank you, Joy. That's really helpful, practical suggestions. And actually, just a plug for our ICHG awards, because we do have small pots of money. So every year we have a research award and advocacy award. And we're looking actually at, about that whole system, but that will continue. And the application process is not very rigorous. We try and make it not very complicated. And that could just be a small grant that could get people started. And really hear you, Joy, around collaboration, meaningful, equitable partnerships. And that's something as well that within ICHG, we are very keen to try and push and promote. Great. And we have a question for you from Alison. Thank you very much, Alison, for the question. And I'm incredibly impressed. You have a PhD internship interview this afternoon and you're attending our ICHG meeting. Thank you so much. What would you say, Joy, are the most important things the UK government can do to help child health on a global scale?
Amazing question. And I had a scary co-chairing of a panel with Michael Marmot on recently, and I actually asked him that. So I think, from his side, social determinants are critical, and we do need to say that. But I think we also need to listen to African governments. So African governments really, really want to meet their child survival goal and their newborn survival goal. And that's 5 years from now. And of course, social determinants are important, but the thing that you can change in 5 years is the health interventions. So I think that the UK government has had a real leadership role in the past for reproductive health, and that will be needed even more, and also helps child health, but also child health specific interventions. So I think that voice is really, really critical. And that overall shift for standing by governments and investing into government systems needs to be thought differently in conflict settings, because in those settings you don't have governments you can go through. So I think also the UK has leading non-governmental organisations, including an MSF office, where the government could do more to support those who are looking after children in Gaza, Yemen, and so on. So in fact, when the UK dropped their 0.7 commitment in 2020 and buried it on a Saturday afternoon, so it wasn't even picked up very much in the news, they cut funding to UNICEF work in Yemen by 70% that they'd already allocated. So there are some really shameful things that have been done. And I think we, as a not advocacy, but evidence-based group for child health, should speak up to say, having not just a voice, but investment in humanitarian response and in health interventions is utterly critical. And it's also the smart thing to do. If their biggest pressure is about migration, what they need to do is actually invest in these settings so there's less pressure for migration.
Thank you so much, Joy. And actually, that's a fantastic idea for the ICHG advocacy group to take forwards as a piece of advocacy action. And I'd encourage people in the audience that are interested in contacting us or joining the advocacy group. So that's the session come to an end. Again, thank you so much, Joy. There is one additional question, but we don't have time for it. But if you want to reply to that in the chat, then please feel free. Thank you so much. And I'll hand over to Samantha and Irva, who are going to chair the next session. Thank you.
Wonderful. Thank you so much. And a huge thank you to Professor Lorne for a wonderful opening session. So I'm Sammy and I'm together with Irva. We are both paediatricians and part of the ICHG, and we're going to be your chairs for this first plenary. We've got 3 talks during this plenary and we'll take panel questions at the end. So please pop all of your questions, ideas and suggestions in the chat as we go, and we will review all of those at the end. So as I said, we have 3 different talks in this plenary. We'll be hearing about family perspectives on disability and the SDGs, clean air in India, and malaria vaccine research. And it's my pleasure to introduce Dr. Tracy Smythe and Dr. Veronica Reichenberger to talk about their work on disability. Dr. Tracy Smythe leads the Child Disability Research at the International Centre for Evidence and Disability, ICED, and the London School of Hygiene and Tropical Medicine, and is an Associate Professor at Stellenbosch University in South Africa. Dr. Veronica Reichenberger is a visual anthropologist and a qualitative researcher at ICED. Thank you so much, both of you.
Great, thanks very much, and good morning, everyone. Hello from South Africa. Thank you for the introduction. My name is Tracy Smythe, and I'm so pleased to talk to you today about childhood disability. I'm a paediatric physiotherapist by background and based both at LSHTM and Stellenbosch University. And we're going to start this session today by considering why disability inclusion is important in our practice. I'll then hand over to Veronica, and she'll speak about parents' perspectives of their child's disability and how they created a film to share their experiences. But first, let me begin with Betty's story. Betty lives in Uganda with her 3 children. Her youngest, Mariam, was born after a hard labour. Nurses told Betty that Mariam was born tired. Mariam struggles to eat, and she can't hold her head up like other babies. In a few months' time, Mariam will start drooling a lot, and people in the community will avoid her, thinking that she has a disease that they can catch. When Mariam is 3 years old, doctors will say that she has cerebral palsy. And around this time, Betty will visit a clinic because Mariam has ear pain. The doctor will focus on Mariam's impairments and will send her to a faraway hospital instead of helping her with the ear infection that Betty's concerned about. Mariam will still have feeding problems. She'll find a research project on nutrition that she believes might help, but they won't let her join because Mariam has a disability. Later, Betty will face another challenge, finding a school that will accept Mariam if she can't walk without help. And so, while children with disabilities have regular health needs like everyone else, they're more vulnerable to poor health and they often require specialised rehab services or medical treatment. But as healthcare professionals, we often only focus on one of these needs and we box ourselves. I'm either a rehab professional or I'm a paediatrician only. And the children with disabilities often fall through the cracks in the silos that we've created. And so ICHG collaborates with the Missing Billion Initiative, which aims to improve access to healthcare for people with disabilities and to help us understand the barriers to good health that people with disabilities face. For example, over half can't afford healthcare, and there's a global lack of training about disabilities. If you think back to your training, how many hours were spent on being able to learn about talking to people with disabilities or speaking about impairments with children as well. Rehab specialists are scarce and many buildings remain inaccessible, even in high resource settings. People with disabilities are excluded from policies and funding, either by being ignored or deliberately left out. And so as a result, health outcomes are worse in all areas of SDG 3. Children with disabilities are twice as likely to be malnourished and die. Children with developmental disabilities in Kenya, for example, were found to be 4 times higher risk of dying than a child without disability. And they're 10 times more likely to be seriously ill. And these poor outcomes continue throughout the life course. And so supporting children with disabilities and their families is essential for their health, their quality of life, and their rights. Without including children with disabilities, we can't achieve our health goals. And this has implications for research as well. So we examined the first 100 titles of registered clinical trials for early childhood interventions, and half of these trials actively excluded children with disabilities, and only 3% targeted children in general. So there is a lot of improvement that we can make here. And this leads me on then to the work that's being done by the GRDDC group. So it's quite a mouthful, the Global Research on Developmental Disabilities Coordinators. And we're a team from around the world. We started in the Global South, working to improve the lives of children with under 5 with disabilities and to support their early development. The challenge is big. We can't achieve SDG 4, the education for all, without including children with disabilities. And the health and well-being of children under 5 is recognised globally as a measure of a nation's development. But there wasn't much information about this. And so our research shows that children are 10 times more likely to live with a lifelong disability than to die before they're 5 years old. There are over 53 million children under 5 with developmental disabilities. And as Joe was mentioning before, data is so important. So in spite of these numbers, while global funding for early childhood development has grown, support for disabilities has dropped to only 2% of the 79 billion spent globally on ECD. We found that there's a need for a clear global plan to support young children with disabilities through early childhood development programs. Some countries have ECD programs that support children with disabilities, or include them, but others do not. But there's no worldwide strategy focused on their needs. A good strategy should include strong laws, clear guidelines for early support and family involvement, and training of healthcare workers. It should provide clear goals, dedicated funding, and agencies to coordinate efforts. And without this plan, the world's commitment to children with disabilities and the SDGs will be very hard to achieve. As service providers, we have a great position where we can champion disability inclusion within ECD. And so, before we go back to what this means for Betty, I have a list of some of our research outputs from GRDDC in case these are useful, and they'll be available on the recording. And back to Betty. Betty can't afford to see specialised doctors or to travel to a rehab centre, but at a local clinic, the parent support group has been set up where parents can meet together to talk and learn about their children. This aligns with the GRDDC recommendation of involving families in care. And this group is facilitated by a parent of a child with a disability and a health worker. And it builds connections with others who are going through the same thing. Now, Betty doesn't feel so alone. She starts to understand her daughter better, and she feels hope for the future. Groups such as these, known as the Ubuntu programs, are run through Africa and known as juntas in Colombia and Brazil. They're also being tested for feasibility in London, and we welcome any questions about these programs as well at the very end. So I'll hand over to Veronica now to share about the parents' experiences of these groups and how they created a video to share their perspectives. Thank you, Veronica.
Thank you very much, Tracy, and thank you everybody for being here today. Thank you also, Tracy, for introducing the Juntos program. So what I'll be talking about briefly today is about a participatory video that we did with caregivers of children with congenital Zika syndrome in Cali, Colombia, who took part in the Juntos program. Next slide, please. So what we did is we combined participatory video, which is a set of tools and exercises, which leads to a video being made together with communities, and the most significant change, which is a qualitative evaluation method to assess the impact of interventions, for example, and then we combined it. So participatory video really is a way of engaging communities and putting their voice in the forefront of conversations. It's a tool that I've been using a lot as a visual anthropologist. And it's really about, not just making a video about somebody or a group, but it's making a video together, which is made with them and by them and for them. Next slide, please. So what we did in Colombia was, we worked with 9 caregivers who took part in the Juntos program. And the program involved, there's many aspects to the program, but it supports caregivers in how to care for their children in daily life. So the process of making the video was, again, to understand the impact. So what were the most significant changes? So it started with discussions around what we were going to do together, what is participatory video, what is the most significant change, what we were looking to understand, and then deciding what stories would be told. You can go on to the next slide, Tracy. Yeah. So then through the workshop also participants learned how to film. Everybody had a turn both behind and in front of the camera, which is very important because you have to learn to be in front of the camera. I know that I always get shy, even though I've worked with this for years. And then learning how to connect the audio, zoom in and out, and etc. And they filmed each other singing songs, and then also having a little bit of a session on how to edit. Next slide, Tracy. Thank you. So essentially, in this, that's participatory video in a nutshell. And then in this process, so it was great because I had initially said that we would choose, of everybody's stories, choose one or two story which resonated with most of the participants. But they said, "Look, wait a second, Veronica. We don't want it. We don't want to do it this way. What we want actually is to get different bits of each stories to make it one story about everybody." I was like, "Okay, great. Let's do that," because essentially that's what participatory video is. Really handing them that choice. And then discussing how the video would be disseminated in spaces like this one today so that they knew exactly who their audience would be. And with that way choosing to the best of their knowledge, how they would be represented, then choosing that representation. They said that many times they felt that people pitied them for having children with disabilities. So they said, "Look, through this video, we want to be seen as strong because we're so strong and we're going through so much and we're so much more than caregivers." So they chose, they said, "Look, we want slow motion in this scene because I've seen it in a film where superheroes come in slow motion. We want the Avengers song at the end." Which is all something you'll see. So they chose all these details to this video. And the reason I want to show this video is, which is then on the next slide, is not only, of course, you'll see then the impact of this program, but it's a good video also to show, first of all, you're hearing the voices of the caregivers as opposed to me telling you what they said, but hearing what are their main challenges, and then consequently through this video, how the Juntos program supported them. Thank you, Tracy.
Esta es una parte de nuestra historia en el cual el programa Juntos cambió muchísimo los aspectos de nuestras vidas y de nuestros hijos.
Por ejemplo, hubieron muchas personas que llegaron con timidez cuando era la parte de socializar entre otras mamás, cada uno contar su historia de cómo impactó entre ellas este síndrome congénito del Zika, abrir sus corazones, y ahora somos una familia, somos unidas.
Y no solo eso, sino el entablar comunicación, el saber que hay más personas con el mismo diagnóstico de tu hijo. Eso es algo gratificante, es maravilloso, es una cosa que te llena. El poder ayudar y tener, aparte de otras vivencias, poder explorar y entender un poquito más a cada uno de nuestros niños.
Sí, igual también nos enseñaron el posicionamiento de cómo debemos sentarlos para evitar otras enfermedades, otros diagnósticos. Creo que es sumamente importante tomar esto en cuenta para nuestros niños.
Sí, minimizar complicaciones como tan pequeñas como de pronto de que puedan broncoaspirar por un mal posicionamiento.
O una esclerosis del mal posicionamiento.
Qué almuerzo tan rico, que llega esa barriga, esa barriga tan linda donde me llego. Ay, sí.
También sobre la estimulación que debemos tener con nuestros niños, el estar constantemente con ellos, que no simplemente se quedaron en terapia, sino que simplemente sea uno en la casa también, estarles promoviendo, insistiendo, porque a ellos todo se les queda, ellos todo se les graba, entonces irlos incentivando para que ellos a un futuro puedan surgir por sí solos, independizarse.
Y hacerlos partícipes cada día, del día a día en nuestras casas, cuando estamos lavando, cuando estamos trapeando, no dejarlos como, ay, sí, se quedó allá en el cochecito y ya, no. Exacto. O sea, un platoncito con almohaditas, no sé qué, y estás pendiente y él está activándose, porque está viendo lo que tú también estás haciendo.
Exactamente, si uno está cocinando, también enseñarle, bueno, hoy vamos a hacer tal cosa, y uno mostrarle lo que uno está haciendo en ese momento para que ellos también tengan conocimiento, acomodarlos bien y estar ellos con nosotros ahí en el día a día.
Y aún la alimentación también, porque somos de las que rapidito sí. Porque tenemos la cita.
Sí, eso es verdad. Creo que tuvimos una experiencia con eso y fue fatal ver cómo nos daban o les daban de comer así muy ligeramente, y sabemos que para nuestros niños está muy mal, se siente muy mal. En la parte de la discriminación, de verdad ese programa nos sirvió muchísimo para darnos cuenta de que no estamos solas, de que nuestros niños no son enfermos como muchas personas los llaman, sino que son niños con una dificultad de discapacidad, pero son niños que entienden.
Tienen una condición diferente a la de los demás prácticamente. No es que estén enfermos, sino que tienen una condición un poco distinta. Aprenden de una manera diferente. Hay que ser un poquito más constantes, pero igual son niños, son tiernos, son unos angelitos, son unos panes de Dios, como decimos nosotros aquí en Cali.
¿La vamos a cepillar los dientes? Sí. Sí. A ver, ¿cómo nos cepillamos los dientes? Ella ve el cepillo de dientes y que uno abre la boca, ya entiende que es una de cepillarse.
Igual también que las personas o los médicos que a veces nos dan unos diagnósticos o cuando uno va a una cita médica es como que no, es que tu niño no puede hacer nada. Y uno antes se afligía mucho. Y ahora ya uno es, no.
Ahora estamos fuertes,
la verdad es que no.
Firmes.
Hemos mirado, estamos viendo las cosas desde otro punto muy diferente y es positivo y es lo bueno.
Y que entre todas las mamás nos damos cuenta que si nuestros niños tienen una dificultad, hay mamás con dificultades mayores que las de nosotros o menores y que en algo siempre podemos estarles aportando.
Exactamente, sí, eso es verdad. También tuvimos una sesión de hacer unos pantalones súper, la verdad. No, igual el pantalón, yo creo que fueron muchas cosas. El pantalón, cada mamá, después nos reunimos en una casa a hacer los pantalones, cada una se llevó sus pantalones y hasta ahora ha sido la maravilla.
Y construimos una familia. Aparte de nuestras familias y de lo mucho que nos ayuda, porque nos ayuda a entender, a integrar más a los miembros de cada una de nuestras familias. Por lo menos en mi caso, mi hija es maravillada porque conoce niños con el mismo diagnóstico de su hermanita. Para ella esto es, ay mami, hay otro niño que se parece a Samara, hay otra niña que es igualita, mira Gabriela. Entonces esto amplía el conocimiento y ayuda como a que la familia se una y se integre muchísimo más al proceso que uno lleva con los niños.
No, y mejora muchísimo la comunicación. A mí en mi núcleo familiar me la mejoró bastante. Con mi esposo la comunicación ha sido muy, muy bien y eso es lo que nos ha gustado, la verdad. Y uno como persona crece a raíz de esto, uno como persona crece, se concientiza en otras cosas, su pensamiento es mucho mejora como llegó al inicio del programa. A raíz de esto, ¿no?
Nos ayuda a ser más fuertes, a tolerar y a responder con sabiduría, que es lo más importante.
Sí.
No solamente somos mamás 24/7, también somos mujeres,
psicólogas,
profesoras,
enfermeras, abogadas, terapeutas,
amigas, médicos,
esposas y mucho más.
Compañeras y mucho más.
Veronica, thank you very much for walking us through that, and we hope you enjoyed the video. Our emails are on the screen as well, and the Ubuntu program has a community of practice as well as freely downloadable programs available, and GRDDC information is there too. Thank you.
Thank you so much, Dr. Tracy and Dr. Veronica, for such an inspiring talk on disability and its impact on child well-being overall. And particularly, it was particularly inspiring to listen and learn about how it intersects with the SDGs and to hear family perspectives as well. Thank you so much again. I think I'm sure many of us are eager to dive into the important topics you touched upon, but we will save the discussion and questions for the Q&A session at the end. So I encourage everyone to add your questions in the chat box throughout our panel discussions, please. And we will now move on to our next speaker, and it's my pleasure to introduce Mr. Abhishek Kumar for our next talk. Abhishek Kumar is the co-founder, CEO of Lung Care Foundation and Doctors for Clean Air India, where he has been instrumental in shaping national awareness campaigns and driving critical policy changes to improve air quality and public health. He is now leading several high-impact pan-India campaigns recognized by the Prime Minister and United Nations. And I think without further ado, I would like to invite Mr. Kumar. Thanks so much for being with us today. And stage is yours.
Thank you so much, Ava. Thank you for the invitation and thank you for that introduction. Let me just share my screen before I start. Um, can you see my screen?
Yes, we can see. Thank you.
All right. Thank you so much. Thank you once again, Sammy and Ava, for the introduction. Good morning to everyone from Lung Care Foundation. It's an honor to be here today to be part of this important conference. I would like to congratulate and thank the organizers for choosing such an important theme of progress towards SDGs and to discuss these issues of paramount importance. Thank you to Emma, Dr. Rebecca, and Dr. Shruti for giving me the time to present the work of Lung Care Foundation. And I'm excited to share first the why behind Lung Care Foundation and then our journey. I'm joining you today from the world's most polluted capital, New Delhi, and will be giving an overview of what we are trying to do to ensure clean air for the children in India. Before I start, let me start with a simple yet profound thought of why we are trying to fight for lung care and clean air. We eat about 3 to 4 times a day. We drink about 6 to 8 times a day, but we breathe 20,000 times a day. Breathing is essential, constant, but often overlooked. Now ask yourself, how many times do you think about eating? I'm pretty sure you're already thinking about what's for lunch, where you want to go for lunch, or what's packed. When you're eating outside, you're always thinking about the hygiene and safety of the food truck or a stall. When you're going out, you're trying to make sure that you have clean drinking water available for you. If not, then you carry your own water bottle. But what about breathing? Do you ever think about breathing? Air is the single most consumed element that we have in our lives. Yet we rarely consider its quality. What happens when the air we breathe is laced with toxins? It impacts every breath, every cell, and every organ. This makes air pollution one of the most urgent public health crises of our time. The very act that sustains our life is the one we least consider. This disconnect is dangerous because it blinds us to the impacts of polluted air. Let's change that perspective today. Well, we all are really keen to measure a lot of things these days. We wear wearables, we are trying to see how many steps we are taking, how our glucose levels are. But have you ever paused to think about how your lungs look like? These delicate organs are a lifeline, but they are also the first to bear the brunt of polluted air. Blackened lungs from long-term exposure to smoking used to be in medical textbooks, but today they are a stark reality for millions living in polluted cities. Let me give you a quick sneak peek from one of our founder trustees, Dr. Arvind Kumar, who's as a chest surgeon gets insights into what our lungs look like. Well, this is what a healthy pink lung looks like. What you see next is a lung of a 40-year-old non-smoker living in a polluted city. And what's most frightening is the lungs of a 14-year-old boy living in a polluted city who has never smoked a cigarette but still has toxins on their lungs. Curious about what's happening inside, we were keen to see if this is actually happening to everyone. So then we decided to put up this billboard in the shape of a lung outside a large hospital in Delhi. When we put this billboard, it was completely white and made of HEPA filters, the same filters that we use in air purifiers in hospitals and homes. Behind this, we put fans to mimic the act of breathing. We were scared that it will eventually turn a little bit dark, but to our horror, it turned completely black. We were thinking that this whole change would probably take a month or so, but this change only takes 6 days. In 6 days of probably inhaling the air in Delhi, this billboard outside had turned completely black. So, how bad is the air that we breathe? Let's try and quantify it. In terms of health damage, as per a study from Berkeley Earth, it found that 22 micrograms of PM 2.5 exposure one day is equal to smoking a cigarette a day. Now, what does this mean for someone in Delhi? Well, annual average PM 2.5 in Delhi was 101 microgram per meter cube. That's about 5 cigarettes a day without even lighting one. And that's 1675 cigarettes a year. When I say 1675 cigarettes a year, I am talking about the damage that 1675 cigarettes would do. And what's scary, that newborns also breathe the same air. It's heartbreaking that our most vulnerable population are taking their first breath in polluted air. Their developing lungs are exposed to toxins from day one, setting the stage for long-term health issues. This is why clean air is not just an environmental issue. It's a fundamental right for children's survival and growth. But you might say that, hey, it is just a Delhi problem or it is just a problem in India. Well, no. Air pollution is a global crisis. 99% of the world population is breathing polluted air that is beyond the WHO recommended standards. Cities across the world are experiencing hazardous air quality. Air pollution transcends borders, impacting millions worldwide. Studies say that about 8.3 million people annually have premature death because of air pollution. And in fact, UK is the first country to have an individual whose death certificate say cause of death says air pollution. This was a young 9-year-old girl living in uh, I think South London, by the name of Ella, where the death certificate says cause of death as air pollution. Does air pollution impact only lungs? Well, our lungs act as the gateway to our bodies, filtering every breath we take. However, pollutants inhaled into the lungs enter the bloodstream, causing systematic inflammation and affecting every organ. From cardiovascular diseases to neurological impacts, the scope of harm is far reaching, highlighting the need for urgent action. Air pollution doesn't discriminate. There's enough research that suggests that it affects us at every stage of the life, from womb to old age, and almost every organ of our body. Pregnant women exposed to polluted air risk delivering preterm babies and babies with low birth weight. Children face stunted lung development, overall development, have higher risk of respiratory infections and asthma attacks, and also have higher chances of developing mental health issues or attention deficit disorder. In adults, polluted air can cause respiratory disorders, cancer, diabetes, and obesity, and much more. And this in turn leads to a much higher burden in old age, potentially even leading to death. Let's look at some numbers now. According to WHO, 1.8 billion children breathe air so polluted that it puts their development at serious risk. And what does that lead to? It about 700,000 deaths in children under 5 in 2021 were linked to air pollution, according to the State of Global Air Report 2024. This represents about 15% of the overall deaths in this age group. That's a number of concern that we need to take care of. These statistics are unacceptable and we must act now. And that is exactly why we founded Lung Care Foundation in 2015 with the vision of care and cure of 2.8 billion lungs in India through awareness, research, and clinical care. Our work for fighting for clean air for better health contributes directly to the sustainable development goals such as good health, sustainable cities, responsible consumption, climate action, and partnerships for the goals. Over the years, Lung Care Foundation has made significant, sorry, just a second. Over the year, Lung Care Foundation has made significant strides from raising awareness to engaging health professionals and conducting impactful campaigns. We are committed to creating tangible change. We believe that awareness about the health impacts of air pollution will create awakening in individuals for the need for clean air and faster action, and this will lead to action by individuals and policymakers for reducing air pollution. We engage school children, college children, youth, doctors, industrialists, policymakers, and multiple other stakeholders. We take multi-pronged strategies such as organizing events, creating school clubs, organizing hackathons, creating songs, making wall arts, putting up billboards, or having doctors present at important events as COP and WHO conference to highlight the need for urgent action for clean air. Let me highlight one creative strategy that we took to highlight the health impacts of air pollution. We created a Guinness World Record for the largest human image of an organ lung with 5,003 children. These children were wearing pink overalls, and then we had some smoke, not actual smoke, but just something that looked like smoke go through them. And then we showed that the lung is turning black. The children took off their overalls and showed that lung is turning black. While this was a Guinness World Record, they also sent the important message of how air pollution is impacting their lungs and individuals need to take action. At Lung Care Foundation, while we are engaging with multiple stakeholders in this particular presentation, I'll focus more on our experience of working with health professionals and why we need health professionals to be advocates for clean air. We believe that health professionals are the best advocate for clean air. Why? Because they are motivated motivators. They are motivated because they see firsthand the impact of air pollution on their patients when they are treating them, and they're working so hard to take care of them. They are best motivators because patients listen to them, policymakers listen to them, media listens to them. They have a position of power which they can use to drive change. And thus, we formed Doctors for Clean Air and Climate Action, which is a network of passionate and informed doctors leading the fight for clean air and climate action. This initiative is an initiative of Lung Care Foundation in partnership with an international NGO called Healthcare Without Harm. We believe that health professionals' voices are among the most trusted and impactful. We are trying to move them from stethoscope to megaphone, where health professionals can educate communities, influence policies, and drive meaningful change. Advocacy for clean air is a natural extension of their role as caregivers. But how exactly are we doing this? We do this through multiple different initiatives. First, we are educating and engaging health professionals about the health impacts of air pollution. While most health professionals are aware that air pollution is harmful for their patients, they're not always aware about the extent of harm or what they can do. Thus, we create multiple resources which are available on our website where doctors can go read about the health impacts of air pollution, get ready-made slides that they can use to create awareness about the health impacts of air pollution, or get posters that they can display outside their clinics to engage with their patients. Second, we have doctors driving conversations with local stakeholders through something called City Forums for Clean Air. These forums for clean air are led by doctors and are multi-stakeholder platforms that bring together a diverse groups of people like industrialists, journalists, educationists, and various other people, creating powerful bridge between policy and action. Next, we are engaging with National Medical Association. I would once again like to thank the organizing committee for choosing this important topic in their agenda. And similarly, we are engaging with medical associations in India, such as Indian Medical Association, Association of Physicians of India, Indian Academy of Pediatrics, Association of Surgeons of India, to drive air pollution and health as a key agenda in their member meetings and try and engage their powerful network of over 400,000 doctors to become advocates for clean air for better health for their patients. We also conduct our own research on air pollution and health. A key study that we did amongst 3,000 adolescent school children, where we did a questionnaire as well as spirometry, revealed shocking findings. We found that 30% of school children in Delhi had airflow obstruction slash asthma, and over 50% of them were complaining of wheeze and cough. While we are doing this study to push for action for clean air, we also use these studies to uh, understand the urgent need for interventions that are required to protect the children. One such intervention is the asthma readiness training and the asthma manual for schools that we have created. As getting clean air would take a lot of time, we are empowering schools to handle respiratory emergencies and ensure that they become safe spaces for every child. Through education, training, and preparedness, we can be ready to handle any respiratory emergency that happens in schools and provide the right treatment slash first action that is required to protect that child. Going forward, we are creating a lot of videos for masses to create awareness. We work with our health professionals to take the research that is published in journals, convert it into simple bite-sized videos that the common masses can understand and would like to consume, and then use these videos to again highlight the health impacts of air pollution and push for action for clean air. Next, we are training and engaging medical media professionals to be better prepared uh, to write articles and report on issues related to climate change or air pollution. And finally, we are supporting policy for action on clean air. This could range from giving material to ministers who are trying to push for bills, having doctors go to courts and give judgments on air pollution, or supporting sorry, or supporting other groups who are working on creating policy documents for clean air. If you, as a health professional, would like to start working for clean air, there's a very useful toolkit that we have developed, which is the Clean Air Prescription, that tells about the basics of air pollution and health and what a doctor can do to lead this fight. As I wrap up, let me re-emphasize that lives of 1.8 billion children is at risk, and collective action is the key to success. At Lung Care Foundation, we are striving towards healthy, happy lungs for all. But this mission requires all of us to contribute. Thank you so much.
Thank you for a really wonderful presentation there. And I'm sure everybody will agree with me that that imagery of the children with the lungs is just absolutely fantastic and really gives a voice to the children who are so affected by this. So congratulations on the world record and for giving those children a voice to show the power of clean air. So we're now going to move on to our next speaker. And if anybody does have any questions for Abhishek Kumar, please pop them in the chat box. I can see we've got lots coming through already. Our next speaker is Dr. Angela Manassian, who is an associate professor at the University of Oxford and the chief investigator of the Malaria Clinical Trials Programme at the Oxford Vaccine Group. And she is going to talk to us today about renewed hope in the prevention of malaria. So I will hand over to you, Angela, now. Hopefully she's here, ready to share her slides. I'm just going to add you to the main stage, Angela. Oh, there we go. Perfect. And we'll just need you to unmute. Are you still there? We'll just give Angela a couple of minutes just to rejoin and bring up her slides. In the meantime, if anybody has any questions from our first two talks, please pop them in the chat box. I can see it's exploded with questions. There's lots going on there and lots of chat. So maybe use this opportunity just to catch up with lots of the answers we've had from the first few sessions this morning.
I wonder, in the meantime, while we are waiting for Angela,
Hi, can you hear
Sammy,
me?
would you be happy to just direct maybe a few questions to our speakers?
Yeah, Angela is back now, actually.
Oh, okay, all right.
Yeah.
I'm so sorry, I don't know what happened there. I could see and hear
happen.
everything, but you couldn't hear or see me. Can you hear and see me now?
Yeah, we can hear and see you.
Oh, great. Shall I get going then?
Perfect. Thank you so much.
Okay, I will. I'm sharing my screen now. Sorry about that, everybody. Can you see that?
Yes, we can see that and we can hear you. So we're all good to go.
Wonderful. Okay, thank you so much. Sorry for the delay. Thank you for the introduction and for the invitation to speak. Much appreciated. My name is Angela. I'm an associate professor at the Department of Biochemistry and Oxford Vaccine Group here in Oxford, where I lead on a clinical malaria vaccine programme. And I'm hoping today to impart some renewed hope in the prevention of malaria to you through the work our group and others have done over the past few years. So fingers crossed. So just by way of an introduction, to those less familiar with malaria, malaria is a parasitic disease that causes 250 million clinical cases and more than 600,000 deaths worldwide. More than 80% of those cases and deaths are sadly in children in sub-Saharan Africa under the age of 5 years. And it's a sobering thought, but a child does die of malaria every couple of minutes. There are 6 types of malaria known to cause human disease. The 2 main ones are falciparum, which is the big killer in sub-Saharan Africa. And the second is Plasmodium vivax, which is actually much more geographically widespread and has long been underestimated in its ability to cause severe disease across all age groups and has this unique ability to relapse. Now, the content of this talk is going to focus predominantly, well, entirely on falciparum, but we do work on both parasites. So before I can go any further, I need to introduce you to the malaria life cycle because it's highly complex. It all starts with the injection of these blue wiggly things called sporozoites into the skin, and that's administered through the bite of an infected female Anopheles mosquito. Within minutes, the sporozoites make their way to the liver, where they replicate, and within about a week, they then burst out of the liver, where they then start to infect red blood cells. And at this point, a continuous and exponential cycle of red blood cell infection ensues. And it's this stage of the infection that's responsible for the horrible clinical disease and mortality that we all know too well. There is also an asexual part to the life cycle where some of these blood stage parasites commit to becoming gametocytes. These are then taken up in the next blood meal when the next mosquito bites, form oocyst on the surface of the midgut, which then releases sporozoites back into the salivary glands of the mosquito, and then they bite the next person, and so the cycle continues. Now, malaria is a parasite with more than 5,000 genes, which is one of the reasons it's been so complicated to make a vaccine against it. People have been trying for decades. But research over the years has identified a few chinks in the armour of the parasite that are susceptible to antibodies at different stages of the life cycle, shown there with the blue lightning. And the first of those targets was identified more than 40 years ago. This was targeting the sporozoite stage that I've just talked about, where they identified a protein called the circumsporozoite protein, or CSP, on the surface of the sporozoite. And it's that the two licensed vaccines are based on. And I'll tell you more about those in a few minutes. And in general, it's not been all doom and gloom with malaria, even before the first licensed vaccines. So there's been a huge progress due to use of insecticide treating bed nets, residual indoor spraying of the vectors, fantastic anti-malarial drugs. So lots and lots of progress. And from the year 2000, cases and deaths were really on the way down, and it was all looking very encouraging. However, if you look here at the global malaria deaths by world region over time, with the blue being all Africa, you can see that by 2015, these deaths had really started to stall. And this was a huge problem and multifactorial. Essentially, areas we were really struggling to see an impact of these preventative measures in parts of Africa with the highest endemicity, the highest burden of disease. This was compounded by resistance to the anti-malarial drugs, by resistance of the mosquito vectors to the insecticides that we used, and all of that coupled with disruption in healthcare services, for example, during the pandemic, a lack of funding, and then obviously the impending threat of climate change, where you risk reimportation of malaria into regions that have previously eliminated it from their countries. It really has been apparent that things have stalled, and we definitely need a vaccine to really add to those preventive measures and finally start to make an impact again. And really, this is just very sobering, but we throw $3 billion at malaria every single year, and we're still getting 600,000 deaths. So it's a really big problem. It's not going away. Now, we are very fortunate, as I'm sure many of you will be aware, that we have 2 licensed vaccines now after decades of trying. People were trying to make a vaccine since the 1980s for malaria. The first licensed vaccine was on the top left here, the RTSS vaccine produced by GSK, licensed in 2021. And the second one is the R21 vaccine, which was made by Adrian Hill and his group here in Oxford. And that was more recently licensed by the Serum Institute of India in 2023. Now, both of these vaccines are recombinant hepatitis B vaccines, and they have the circumsporozoite protein that I mentioned on the surface of the sporozoite incorporated into that hepatitis B vaccine platform. And they're given in a strong adjuvant to enhance the immune response, either using AS01 with GSK's vaccine or the Matrix M adjuvant with Novavax's vaccine. Now, they both induce very high levels of antibodies. They block infection at this liver stage. They stop the sporozoites getting into the liver, and they produce moderate to high efficacy in the first year after 3 doses, up to 75%, which is, fantastic. That hadn't been seen before. And R21 in particular is cheaper and more scalable with its partner, the Serum Institute of India. And recent modelling analysis has shown that they're both very cost effective, and R21 is certainly expected to make a big public health impact. Sorry, I'll just correct myself there. The cost effectiveness of R21 has been demonstrated by modelling more so than RTSS, and really expected to make a big public health impact in the way that RTSS already has. So that sets the stage for the current malaria vaccines and is all very positive. That being said, there is a room for improvement here. The WHO preferred product characteristic is seeking 90% efficacy, not 50 to 75%. That's the new goal. And there's problems in a low uptake of the 4th booster dose of these vaccines in the 2nd year of life. And the other problem is that neither of these vaccines have any effect at the blood stage of the life cycle. So even if a single parasite slips through the net, makes it through into the liver and out into the blood, then clinical disease will ensue. And so our work over the last 15 years or so has been to try and come in with a second line of defence at the blood stage to actually act by stopping any of these parasites that are leaked through the liver from getting into the red cells and at that horrible cycle of infection ensuing. That's what we've been trying to stop. Thinking about the blood stage of malaria, it's been even more difficult to make a vaccine against the blood stage. Why? Well, this cartoon, which I hope will work, yes, will hopefully explain to you why, at least in part. So you're looking at a malaria parasite there, just entered the bloodstream, it finds a red cell, it reorientates itself onto its apical end, it drills through the red cell wall, shedding its outer protein coat as it does so. And then, as you can see, within seconds, it's in and it multiplies at an exponential rate, bursts out and infects new red blood cells. So you can imagine you have to have a very high concentration of antibody there ready and waiting to stop the blood stage parasites getting into the red cells in the first place. So a very, very big ask, very complex biology, rapid exponential growth of this parasite. And in addition, the blood stage parasites historically have had a lot of genetic variation. So they're what we call polymorphism. And the problem with that is you then risk having only strain-specific efficacy. But what you really need is for your protein targets to be conserved across all isolates of falciparum malaria. The other thing is that they always have another way of getting in. This is what we call redundancy. They have used different targets to get into the red cells, a bit like having a spare key to a lock. So they're very, very clever. And so lots of reasons why making a vaccine against blood stage parasites has been so tricky. But more than 13 years ago now, our lab made a very exciting advance when they discovered another blood stage protein called RH5. Now, RH5 has to get into the red blood cell by interacting with basogen, a red cell receptor on the surface of the human erythrocyte. If it can't bind, through that mechanism, it cannot get in and the parasite will die. So our work over the years has been to make vaccines that specifically block that critical interaction between RH5 and basogen to make sure we can stop the parasites getting in. And so we first showed in Aotus monkey model in non-human primates that this vaccine was incredibly promising. So what we did was we undertook challenge studies in these Aotus monkeys where the animals were vaccinated with RH5 and then they were challenged with falciparum malaria. And you can see here in the control animals, the parasites were growing rapidly in pink, whereas in the vaccinated animals, half the animals were actually sterilely protected, so that you didn't detect the parasite at all. That's the straight line. And half of them controlled and cleared the parasite over time. And from this work, we were able to identify a correlate of protection, which was the amount of RH5 specific growth inhibition activity, what we call GIA in the field. And what was clear was that those animals who were protected against the challenge had more than 60% GIA. And if you look at the blood stage vaccines historically that have failed in phase 2 efficacy trials, these have always elicited significantly lower amounts of GIA than that 60% threshold, so confirming that. And this has since been validated as a mechanistic correlate through transfer of monoclonal antibodies in non-human primates and also in humanized mice work. So great that we have a correlate for blood stage. And so after this important work, we were able to complete clinical trials with RH5 in humans for the first time. And essentially, we started with a viral vector-based RH5 vaccine approach, first in UK adults and then taking that vaccine to Tanzania. That wasn't further developed, though, because we then were able to make a soluble protein vaccine that was able to elicit the really high levels of antibodies that we know are so important in protecting against blood stage malaria. And we had very promising results first in UK studies here, where we had an initial positive readout from a human challenge study here. We then took the vaccine to Africa in Tanzania with Novavax's vaccine Matrix M, and again had very promising results in adults and younger children and infants, with the highest levels of functional immunogenicity ever seen with a blood stage vaccine. That work was published earlier this year. And this was work with Ali Olotu, the PI in Bagamoyo in Tanzania, who we've worked with for many years now. So really exciting results from our phase 1 trials. And really the two take-home messages from these trials are, first, on the left, we see a 5 to 10-fold higher ICHG response to this vaccine in African children compared to what you see in UK or African adults. And if you give the third dose of the vaccine at a delayed time point at 6 months, rather than giving them at monthly intervals, you see not just a slightly better peak, but this very impressive improved longevity in the immune response, which is maintained out to 2 years, in stark contrast to the rapidly waning titers of antibody you see in a schedule where you give 3 doses of the protein vaccine monthly. So delayed boosting here seems to be really doing something and changing the kinetic of the response. And of course, durability is so important for malaria because you have children who need to be protected over a malaria season in seasonal settings, and in perennial areas, a high burden, they need to be protected all year round. So this is really something to crack. And so this shows you the iterative improvement we've seen with our vaccines. You're looking here in the graph at the levels of growth inhibition activity over time, with the threshold that was protective in the monkey model shown by that dotted red line. And you can see here that as we moved from previous antigens to Rh5, from viral vectors to protein vaccines, from monthly to delayed boosting, and finally from UK adults to African children, we've been able to not only match but exceed that threshold level of the vaccine-induced GIA that was associated with protection in the monkey model. So for the first time last year, we were able to ask the question, does this level of GIA actually protect against clinical malaria in vaccinated African children? Because obviously that's all that really matters. So we were very excited to be able to do our first phase 2B efficacy trial in Burkina Faso in a seasonal setting in the Nanoro area with Professor Halidou Tinto and his amazing team, who were heavily involved in the R21 and RTSS phase 2 and 3 trials. So here we conducted a randomized controlled trial where they vaccinated 360 5 to 17-month-old children at a single site. There were 2 control groups who received the rabies vaccine and 2 vaccine groups who received Rh5 with Matrix M, delivered either in a monthly regimen shown here in groups 3 and 4, or with that interesting group where they get a delayed dose at 5-6 months. All of the final vaccinations were aligned, and then we were able to monitor for clinical efficacy over the malaria season. And so the primary endpoints were obviously safety and reactogenicity and clinical malaria at 6 months. So we had initial 6 months monitoring for our primary endpoint starting 2 weeks after the 3rd dose. And based on historical precedents, we were very much braced for 0. So a lot of nail biting at the time. Now, the immunogenicity data came through, which was extremely interesting. So this shows you the anti-Rh5 IgG results as measured by ELISA and shown by vaccine group. So you can see the controls in blue, the delayed 3rd dose Rh5 regimen in orange, and the monthly in green, shown at baseline on the left. And then on the right, 14 days after the 3rd and final dose of vaccine. And what you can see is that there are no anti-Rh5 responses at all at baseline in any group, and none in the rabies control group after the 3rd vaccination. By contrast, in the vaccine groups, you can see very high responses and significantly higher RH5 responses in the delayed versus the monthly group, with geometric means of over 800 micrograms per mil in the delayed versus 600 in the monthly. And over on the right here, you can see the growth inhibition activity, the GIA. And again, you can see significantly higher GIA in the delayed group compared to the monthly, 79% compared to 74%. And importantly, though, in both groups, more than 80% of children were over that 60% target. And this was at the time we were starting to monitor for efficacy. So we were really excited to get in the efficacy results. This is in April just this year. The table on the right there shows that we were able to meet our 6-month primary endpoint with our delayed third dose regimen in orange, which gave a vaccine efficacy of 55%, which was a first for any blood stage vaccine. It was lower in the monthly group. And then on the left here, you can see a Kaplan-Meier, which illustrates the time to first malaria episode by a vaccine group. So again, you can see the controls in blue, the delayed group in orange, and the monthly in green. And you can see the majority of malaria cases occurred during the first 4 months of that 6-month follow-up. But the monthly group in green did accrue some additional cases over the following 3 months. And this was borne out by the vaccine efficacy. The interim analysis that we did at 3 months, where actually both groups were very effective, more than 50% and very statistically significant. But this dropped off in the monthly group by 6 months, whereas the delayed group held with this 55% efficacy. And what we did then was we had some secondary case definitions of malaria. So our primary case definition was fever or history of fever with a parasite count of more than 5,000 per microliter. But we used some secondary case definitions as well, looking at a slightly higher cutoff for parasites. And at this higher cutoff, we saw the vaccine efficacy was even better, nearly 70%. And a post-hoc analysis, looking at even higher parasitemia cutoffs of more than 50,000 and more than 100,000 here on the bottom, showed vaccine efficacy of more than 80%, and that was in both regimens. So really fascinating, because this really supports the idea that this vaccine works by suppressing parasitemia, and therefore is highly suggested that this vaccine could be very effective at preventing any severe cases of disease, which is obviously the ultimate goal here. So just to summarise this, very exciting for the blood stage vaccine field, the first vaccine to show any significant protection on its own in an endemic area. This is due to be published actually next week in the Lancet Infectious Diseases if you're interested. But we don't stop there. We need to think of ways of improving this. And in fact, there's been a lot of biology done around the RH5, and we now know that it's not in isolation. It's part of a much wider complex of actually 5 different essential and highly conserved proteins shown here. So RH5 is here in red, but there's several other proteins here that interact with it and are important in the interaction with the red cell membrane. And one in particular, the green long protein here called RIPA, we have focused on in combination with the blue one, CYRPA, and we've made a fusion protein of both of these, again, with the matrix M adjuvant. And preclinical work has been hugely exciting. It shows that the combination of these 2 proteins with RH5 actually outperforms RH5 in that model. And this combination vaccine using different blood stage components is now in phase 1 testing, both in the UK and Tanzania. And so the next step for us is to continue the clinical development of a second generation multi-stage vaccine. So this is where we are going to use the R21 vaccine as the first line of defense at the liver stage, but we're going to pair it with an RH5 or R78Z based vaccine where we get this additional line of defense at the blood stage. The idea is that you then get higher efficacy and more durable efficacy, and especially if those 2 vaccines synergize, which is the hope. And so we now have a series of trials underway, due to start early in 2025, to explore this combination. And so this has brought a huge amount of excitement to the malaria community going forward. And again, we're biting our nails all over again at this point. Before I finish, a very quick mention of transmission blocking vaccines. I can't not mention these. Transmission blocking vaccines offer a new approach where they target malaria parasites in the mosquito host itself. They're designed to induce antibodies which are taken up in an infectious blood meal by the mosquito and then interfere with the sexual processes in the mosquito to stop the oocyst forming. And so blocking onward transmission through biting. There's a number of target antigens shown on this slide that target either the gametocytes or the oocyst itself. And the most promising candidate comes from the NIH in the US, the PFS 230, which is conjugated with the cholera toxoid used in other conjugate vaccines and delivered with matrix M. And this has shown some very exciting initial results and is now in more extensive field testing. The challenges with this type of vaccine are that it's an odd concept. It doesn't give you direct individual benefit, but it benefits the community. So the idea is if you deploy it in a community, it should reduce the risk of transmission to your neighbour or household, and thereby reducing the number of circulating infectious mosquitoes below a level that is able to sustain transmission. So it's a little bit different. There's some complexity around the fact you need to give a lot of it to all age groups at the same time, especially if you want to eliminate malaria from an area. And currently the route to licensure is unclear, but a lot more to come from that and really exciting results with the PFS 230 vaccine and something we'll be thinking of incorporating into our strategy also. But for us, for the time being, this is our pathway, hoping maybe to licensure, but we won't get ahead of ourselves just yet. But this is just to give you a sense of the timeline here and how hard it is to get these vaccines down this pathway. So we first identified RH5 in 2011. It took 13 years to get it into the first phase 2 efficacy trial, much longer than it did for the COVID vaccines, as you know. But we're really hopeful that we will end up with a combined multi-stage product that will give higher efficacy and hopefully more durable efficacy. That's the ultimate goal. So a bit of a whirlwind, but just some take-home messages. I hope I've demonstrated there's been huge progress in development of these vaccines. We've got 2 approved single-stage vaccines being rolled out now, multi-stage vaccines in the clinic. The best vaccines are still only partially effective, though, in children, and again, only against one type of malaria. I haven't even touched on the other types, like Vivax. And if you really want to eliminate or eradicate malaria, you really need to protect against all the malarias, and in adults as well as children. So there's undoubtedly a huge amount of work still to do. And I will leave it there. Lots of people to acknowledge who have helped us on the RH5 programme to date in Burkina Faso, in Tanzania, in our lab, at the London School, the NIH, and the Serum Institute of India and Novavax, and the lab at home who've spent more than 15 years working on RH5 vaccines, and our many helpers in OVG and the JENA who've given massive support to our clinical trials. We couldn't have done it without them, and our many global partners and collaborators who've provided the funding. Thank you very much, and I'm happy to take questions if there's time. Apologies if there isn't.
Thank you so much, Dr. Angela. Very promising results and amazing to learn about the promising progress on the malaria vaccine. Very inspiring talk. Thank you. And thank you to all our presenters for those insightful and thought-provoking discussions. It was really informative and very much sobering overall. I think we would like to open the floor now for questions and discussions, as we have lots of questions, but very little time for discussion and questions before our comfort break. So obviously not surprised to see lots of thank yous for our wonderful presentations on the chat box. I will start with Dr. Angela first. We have 2 questions for you. I will try to combine them for the sake of time. Helen was asking, as we all know, vaccine hesitancy is an increasing problem in many countries now. Do you see this is like to be an issue for malaria vaccine rollout in the highest prevalence malaria regions, Dr. Angela? And then the other question was from Benjamin. So he was asking, is there hope behind malaria vaccines that we will no longer need traditional chemoprophylaxis, or will vaccines have to be used alongside traditional chemoprophylaxis overall? Thank you.
Oh, thank you very much for the questions. So vaccine hesitancy, yes, that was a really good question, and it's so important and one that we have to be mindful of, and going forward with any new product. And it's taken an awful lot with the RTSS community and the R21 community to really impart the benefit of these vaccines that have been made in the West and are now being used in the South. Lots of challenges with those and with the rollout of those vaccines that I'm aware of, but huge amounts done to really engage the communities in those endemic areas. So there's an awful lot we can learn from that. So by imparting a new vaccine, I think there's an awful lot we can build. And if we were going alone with this without anything as a precedence, it would be very, very difficult. So I think we're lucky in that we have that to base any new next generation vaccine on. But yes, it will take time and persuasion, I think, to persuade people of the benefit of another new candidate. And we'd have to definitely explain how it builds on the previous candidate and gives, if it's shown to do that and to give better efficacy. So, but yeah, a huge amount of work to be done on that. Really, really important. Now I've forgotten the second question. I think it was the role of chemoprophylaxis, was it?
Yes. You want
so
me
yes.
To
so
yeah. Sorry.
No. I think that's fine. I think it's a really important question. And there has been recent publications. Brian Greenwood has published on the efficacy of the RTSS vaccine with and without the seasonal malaria chemoprophylaxis, and there's huge evidence that the combination of the two far exceeds either of those two interventions alone, which is really important. What's really interesting and relevant to us is that the chemoprophylaxis offers blood stage immunity, essentially, in the way that our vaccine should hopefully do the same. So that it's possible that if the blood stage component as part of multi-stage gets taken forward, that you may not need the seasonal chemoprophylaxis as well. And that would obviously be highly cost effective not to need those multiple interventions. It's also really important for any vaccine to demonstrate efficacy on its own in its own right, in the absence of any additional tools. But I think in reality, we will continue to need as many tools as we can to really get on top of this disease. So it's certainly, we cannot say goodbye to those drugs just yet. Absolutely not. I hope that's answered the question.
Yeah, perfect. Thank you. I now have a couple of questions from the chat directed towards Abhishek Kumar, and two similar questions, so I'll combine them into one, basically asking about, have there been any policy change from the Indian government on fighting air pollution? If you have any comments.
Yes, thank you so much, Samantha, and thank you for those who asked the question. I won't say that there is all the change that we need for the action to take place, but there have been a lot of policy changes that have been coming over the years. There is a national clean air program that was made in 2019. There are standards for the India like leapfrogged on BS6 from BS4, which is a better emission standard. There is a push for electric vehicles across the states. So there are a lot of such small initiatives and big initiatives that are being taken at a national level. But then air pollution is a massive problem. It's a systems change that is needed. There are multiple factors from industries to vehicles to individuals that are leading to air pollution. Over that, for cities like Delhi, geography plays a huge role. So what happens in winters is that the geographical position of Delhi is so that all the particles get blocked in the area and are not able to escape. And that adds to the pollution. A key thing that leads to air pollution is crop burning. This only leads to pollution maybe for 1 to 2 months, but then it happens every year. Now there is a policy from government banning crop burning, but then it still happens because there's a lack of implementation or the fines are not big, and there are bigger systematic issues like the crop patterns that need to be changed to stop that. So there are these things that have happened, but I won't say that they have led to clean air. Referring to specific engagements by doctors, so there are multiple court judgments as well as policies that state the research from Lung Care Foundation or the work of a certain doctor. And just today itself, the leader of the opposition party in the parliament has submitted a document that quotes research, the children's research that I highlighted, asking for the current government to take a stricter stand on clean air.
Great, thank you. I'm going to pass over to Irva now, who had some questions for Tracy and Veronica.
Thank you. Yes, I will now ask a question for Tracy and Veronica, if that's all right. Sorry. I know you briefly answered this question on the chat box, Tracy, but would love to hear the answer briefly here as well, particularly for our listeners who can't open the chat box for some other reasons. As this, I think, was a very good question. So Rebecca was asking, so she's currently working on developing early detection and diagnostic tools for pediatric neurodisability, and she is often facing the question, so what, and wondering how best counter this question when faced with funders who perhaps are more focused on survival and infectious diseases. Thank you.
Great, and it's such an important question and something that we come across really often. And I think it has to be founded in a human rights-based approach to start with. So the question really is, why should I care about a person who is alive at the moment and struggling with long-term difficulties versus trying to save lives? And that's a really difficult choice to be making. And hopefully what I've been able to highlight in the chat is that when we make services inclusive for children and people with disabilities, we make them inclusive for everyone. So what we find is older people have more access because then there are accommodations that have been made, and they've also found that there are cost savings in this as well. So I think even though we need to be making the human rights argument, there is also an argument for economics as well. And so including children with disabilities in care. So for example, when they become teenagers and looking at HIV services, and we're not going to be able to reach our 2030 goals for HIV services within the 1990 if we don't include people with disabilities, because they make up the vast proportion of the remaining 20% in some cases. And so I think in these cases, there is, whilst there's a right-based argument, there's also an economic-based argument and an inclusive-based one. And I think at the end of the day, it matters to the families. It matters that I have quality of life. It matters that I can leave my child safely to go to work and they are in an environment where they would be able to play safely. And so those are the kinds of arguments that I would suggest making. But I think the most powerful case for that is actually the voices of the parents and caregivers themselves as well. And so bringing them in as early as possible, and just highlighting on the end of the video that was made, where we're not just caregivers, we are wives, and we are nurses, and we are teachers, and we have all of these different roles as well. Is really important.
Wonderful, thank you. And thank you to all of our speakers this morning and to everybody that's engaged in the discussion that's going on in the chat box. Lots of important discussions and lots more to carry on with. So that brings us to the end of our first plenary session, and it is now going to be a break time. We'll be restarting again on the main stage at 11:40. We've had a slight change in the programme because unfortunately our next plenary speaker can't join at 11:30. So we'll restart at 11:40. It'll be a break time for everybody now until 11:20, and then our breakout rooms will be open between 11:20 and 11:40. So for those of you not familiar with the Medal platform, you should be able to see on the left-hand side of your screens, just below the main stage icon, there is a little icon that says breakout sessions. If you click onto that, there are a few different options of breakout rooms that you're able to join. So take your pick about which one you would like to join and hopefully have a good conversation with a few people in the room, and then everybody will come back to the main stage at 11:40. Thank you again so much to everybody that's already spoken, and to everybody that's been so engaged online from all over the world.
Hello and welcome back everyone to Plenary 2. I hope you've all had the chance for a bit of a break and some all important networking. So this next plenary will focus on transformation of the SDGs. And we're going to start off with Dr. Marco Karak. Dr. Karak is a UK-based paediatrician and a public health doctor currently working at the London School of Hygiene and Tropical Medicine. So today he's going to be talking us through the Sustainable Development Goal of Zero Hunger and his work to do with this. So without further ado, I'd like to invite Marco to the stage and see what he has to tell us.
Great, thank you very much. So let me just check. Is my screen showing okay?
Yep, can see that.
Fantastic. So big thanks for the invite to share, and it's always a pleasure to be at the ICHG meeting. So I'm currently a public health doctor working in research and teaching at the school, but in a past life did do pediatrics, and so I'm not sure, depending on how you see it, either swap to the light side or the dark side, but certainly always a big place in my heart for pediatrics, and a pleasure to present today. And I start off our talk with this map. So Zero Hunger, Prospects and Progress. So it's trying to shatter some stereotypes about where hunger exists. And this is a map of post-World War I Europe. But I think it's really important to remember, and we're living in a time of great instability. So yes, this is in the past, but I think also big threats. This is a future map. So I have three key messages. Firstly, that hunger and malnutrition are major global public health problems. Secondly, they have serious adverse effects on children, both short, medium, and long term. But thirdly, and I think really importantly for you, the next generation of global health leaders, are that hunger can be defeated. Effective interventions do exist, but we need political will, we need more research, and it needs your input. It needs the next generation to take it forward. So firstly, about being a global public health problem and worsening. So I just want to start off with some definitions, some reminders of what hunger is. So hunger is an uncomfortable or painful physical sensation caused by insufficient consumption of dietary energy. And it's related to food insecurity. And I think we've all been hungry, but food insecurity is when that becomes prolonged. So it's about prolonged decrease, prolonged lowering of both the quality but also the quantity of food. And there are severe food insecurity scales, and sadly there are many people living worldwide, millions, with a state of severe food insecurity. Food insecurity, if prolonged, results in malnutrition. So malnutrition is any condition in which deficiency, excess or imbalance of energy, protein or other nutrients adversely affects body function or clinical outcome. We commonly define for program, for clinical purposes, undernutrition using anthropometry. So again, a quick reminder of the major forms of undernutrition. We have stunting, which is often seen as a proxy of chronic malnutrition, but also chronic ill health. And I think really important to bring a child health voice to the table to an understanding of nutrition. So stunting is marked by low height for age. Wasting is a more acute stage marked by rapid loss of weight and a low weight for height or low mid-upper arm circumference. Underweight is a mix of the two, low weight for age. But also I think really important to remember edematous malnutrition, kwashiorkor. We have micronutrient malnutrition, so some of which have signs and symptoms like eye signs for vitamin A, anemia for iron, skin changes for zinc, etc. But really important to remember that many result in increased risk of morbidity, mortality without obvious signs. And it's also important to remember that we live in a world of the double burden, and if you include micronutrient malnutrition, the triple burden of disease, where we have also coexisting in the same communities, countries, and even in the same households very often, overweight and obesity. So it's a complex world and a bigger need than ever to take action to make progress. It's important to remember that great progress is possible. So there was hunger in the ancient world, defeated. Again, interesting to note, the first clinical trial in recorded history, about 600 BC, recorded in the book of Daniel, was in response to hunger. So it was a nutrition trial. There was hunger at the start of the modern age, Industrial Revolution, again, greatly decreased nowadays. There was hunger in the 1930s, in the Great Depression. There was great hunger. So one of the single biggest famines in the world, the 1960s China famine, affected some 55 million people. Many say that's conservative estimate, 55 million deaths. And all of these were defeated. We moved forward through an enabling environment. So progress is possible. But it's also sobering to remember that we have persisting challenges. So there's a climatic challenge due to global heating. Sadly, conflicts are increasing rather than decreasing globally. And again, a major driver of malnutrition, hunger. There's COVID, or there was COVID, but again, it's just a matter of time till the next pandemic. Infectious diseases still remain a major challenge. And also, I think all of these are challenging enough without the frankly chaotic, corrupt, and incompetent global leadership that we often face these days. So all of this results in this kind of map where hunger, malnutrition is sadly all too present in all too many settings and rising and a bigger threat than ever. In the 2020 Global Nutrition Report, an estimated 1 in 9 people globally, so 820 million, so a really sobering and sad statistic, were undernourished or hungry. And at the same time, 1 in 3 people overweight and obese. So how are we doing? So the latest Global Nutrition Report looks at low birth weight. Sadly, only 15 countries are on course, 82, no progress or worsening. So this is one of the first steps which makes infants vulnerable. And again, many things we know how to address, how to reduce low birth weight, far too few things happening. There is progress, but limited progress and much less than we'd want to be on exclusive breastfeeding. Again, a key driver of early life undernutrition, early life nutritional risk, early life health risk. Those combined can lead to childhood wasting. So again, sobering, I mean, good news, but also sobering that 20 countries only making some progress, 23 making no progress or worsening. And I think the lack of data is itself really quite striking and notable. So data quality, and if we can measure it, it's much more likely to progress. Anemia, again, lots of countries failing to make adequate progress on anemia, only 1 on course. Childhood stunting, again, some on course, but really not enough. And childhood overweight and adult obesity, everybody off course. So really sobering stats and really highlighting the work that needs to be done. But given this is a UK audience predominantly, I think it's also just important to remember that it's not just a problem elsewhere, as my first map highlighted. So in Europe, there are an estimated 333 million people malnourished. So those admitted to hospital, those in hospital, those with underlying cancer, etc. So it's a big threat, even in Europe, and it has huge costs. So an estimated 170 billion to European countries. And it's a cost we really can't afford, and we need to tackle, and we need to be proactive. I think it's one thing to note that hunger is prevalent in some of the poorer countries of the world, some low middle-income countries. But I think also it should be pretty scandalous that it's present in the UK, in the 6th richest economy in the world. There's hunger. So in last year, 2022 to 23, there were some 3 million food parcels, so food banks rising exponentially. And this one, I find a really heartbreaking statistic that the average height of children in the UK has actually gone down. So again, I thought when I started working in Malawi 20 years ago now, I thought I'd be the last generation dealing with undernutrition. I thought it would be transitioning to a problem of over. I never dreamt that the undernutrition side would be a problem not only globally, but even in the UK. So I think lots of work to be done. And the work needs to be done because hunger and malnutrition have serious effects on children. So there are short-term effects. Globally, there's some 4.9 million under 5 child deaths per year. So that's 13,000 per day. That's 45 airlines per day crashing. So just think of the scandal and the news that just one airliner going down has. 45 a day, very rarely reported, very rarely realized by many people. And at the center of that, undernutrition in its many and varied forms underlies some 45% of those deaths. So what that's saying is if there were a child who had pneumonia or diarrhea or measles or other infections or conditions, if they're well nourished, yes, it's a serious condition, but they're also more likely to survive. If they're undernourished, they're firstly more likely to get the infection, and secondly, less likely to make it through. And some forms of undernutrition, so wasting in particular, has a particularly high case fatality. So almost 1 million deaths per year just due to wasting alone, and deaths due to the other form of severe malnutrition, edematous malnutrition, kwashiorkor, not even captured. There are also important midterm effects. So it's not just survival. It's also we need to help children survive, but also thrive. So it has really important adverse effects on development and therefore on education. So those first few years of life, the first 1,000 days of life, especially from conception to age 2, are the critical years where the brain, the neurological system is developing. And we need to give children that chance, that early head start to be the next generation of clinicians, teachers, academics, people contributing to society. These are slightly old figures, but sadly, I don't think so much has changed. That 200 million children under 5 were not fulfilling their developmental potential. These are more likely to do poorly in school, to have low incomes, and to provide poor care for their older children, so perpetuating that vicious cycle of intergenerational poverty. But there's also long-term impacts. So increasing work from many studies, follow-up of the China famine, which we've been involved in a little bit, follow-up of famines of hunger survivors from post-World War II Europe, and increasing evidence and realization that that early life exposure is not only that short-term threat, but has a big implication and greatly increases the risk of long-term non-communicable disease, heart disease, diabetes, metabolic syndrome, even mental health conditions associated. So really important to think of nutrition as an investment, which also pays back in the long-term future. So just 2 reviews that we did in the last couple of years showing that impact on non-communicable disease and also on development and behavior and cognitive development. And this has life cycle, community, country, and global consequences. So a baby who's low birth weight is a lot more likely, is at high risk of becoming a child who's wasted, in turn a child who's stunted, an adolescent who's stunted and hasn't fulfilled their full potential, an adult who, again, hasn't got that chance to fulfill their full potential. And that life cycle can persist. So there are many reasons why we need to tackle this thing, especially in the first 1,000 days of life. But we also need to focus on school-age interventions for older children, adolescents, also pregnant lactating women, another particularly important target group, as well as other key target groups. So in our work in Malawi, for example, we and many others flagged that children with underlying disability and chronic disease are much, much more likely to be malnourished. So there are specific subgroups who really need extra care. And this really matters, not only for individuals, not only for families, but it matters for communities, entire societies, and entire countries. So huge, huge effects. But the good news is that hunger can be defeated. Effective interventions do exist. And again, starting with Europe, what can we do? What can we do tomorrow in clinics, in the settings where we're working? Simple things, actually thinking about malnutrition. So is it there? Assessing children, assessing nutritional state, asking about it, screening, monitoring, providing timely care where it's needed, providing equal access to medical nutrition, so having nutritional support services in the settings we work. And again, drawing on complementary and synergistic skills of others in multidisciplinary teams. So how often are we working with dietitians, nutritionists, and others to improve the health and nutrition of patients in our care? And again, just being part of the education, the advocacy about nutrition, both for patients, but also, I think, really importantly, fellow health professionals. Again, interesting to know how many people actually are aware of this, but just in the last 2 years, the Association for Nutrition published a curriculum for undergraduate education in nutrition, so covering these topics: malnutrition, including overweight and obesity, and underweight, and undernutrition is one of the major topics. But again, do we have enough in postgraduate care? Again, as training in pediatrics, I was very struck. I knew perfectly well the importance of breastfeeding and could answer lots of exam questions on that. But that's a whole different skill set to actually being able to support mothers who are struggling with feeding their infants. So do we take nutrition seriously enough in our postgraduate training? And again, can you be part of the solution in improving that? So I know there's some really nice pediatric groups who are looking at supporting infant feeding, both in pediatrics and GP. But are you part of that? Do you know how to support nutrition? I think if not, there are lots of resources to help. It's about career choices. So this is an old but classic book by David Morley and Hermione Lavelle, who are some of my early role models in global health. And how do we choose our careers? Is it the disease palace, or are we thinking about community-focused care, how to really improve things? And ultimately, perhaps, it's down to politics. As the saying goes, if you elect a clown, expect a circus. And sadly, that's what we've had in many countries over many years when actually work needs to be done. And it's fantastic. But it's also, I think, interesting to reflect that actually it was footballers and people who are not naturally associated who've actually been the greatest champions, the greatest allies in our fight for good nutrition. And important to think about your role as clinicians who are trusted like very, very few other people in the world. What role can you play as social activists moving the agenda forward, trying to create a better future? So what to do? So we need multiple actions at multiple levels. So there's no one silver bullet. We need to focus on the immediate determinants. So most of us will be working on the clinical side, on improving the short-term care, addressing underlying nutritional deficits, addressing underlying health issues, so on those immediate things. But there's also great need not just to work on, but to speak up about and to engage with the underlying determinants, the global system, the resources, the norms. So why don't we have more investment in hunger in nutrition? And it's about combining nutrition-specific and nutrition-sensitive actions. So if you haven't seen it before, again, really recommend to have a look at the Lancet series on malnutrition. And just some examples of nutrition-specific actions are community management of severe acute malnutrition. There's breastfeeding promotion, and again, a really key intervention and really key to remember that breastfeeding is not primarily about nutrition. It's also about supporting immunity. It's about microbiome. It has a much, much wider role. So it's not just a nutritional role. It's about supporting good quality, diversity, as well as quantity of food in infant young child feeding. And school feeding programs, another really fantastic example of something that's really has high impact, very supportive, gives both the health, educational, many other benefits, many social benefits to school-aged children. Then there are nutrition-sensitive actions. So to support children, we also need to support mothers and families. We need to support improved crops, improved yields. We need to move from this picture in the third right to bigger scale, more fertile, more productive agriculture. Because the good news, and one thing to really remember, is that tackling hunger, tackling malnutrition is an amazing investment. So for every $1 invested, an estimated 16 is given back. So huge yield. And it's not just the zero hunger aim, but it has benefits across health. It has benefits across education, development, gender equity. So many, many sustainable development goals are affected and are positively influenced by improving nutrition. And the time to act is now. So John Boyd Orr was a doctor, a biologist and a nutrition expert who was active around the time of the Second World War and in the rebuilding of Europe, in the rebuilding of global systems and structures. He realized, and many others around him realized, that we cannot build peace on empty stomachs, and there can be no peace so long as a large proportion of the population lack the necessities of life. So world peace must be based on world plenty. So just to recap, so hunger and malnutrition, they're major global public health problems, and there are big dangers, big signs already that things are worsening rather than getting better. It has a serious effect on children, short, medium, and long term. So it's an investment. We shouldn't see it as a cost. It's an investment into the future, and it can be defeated. So many effective interventions exist, but we need your input. We need better politics, we need better research, and we need more action. So big thanks, and I'll close there and then open to questions. And also just a little cheeky reminder that you do get in touch, do email us. One of the things I love about working in this field is it's a quite small community, and that's lovely because it's a nice community, but it also means there are far too few of us working on it in the world. So please do reach out. There's lots of courses, lots of things that we can do, lots of projects on malnutrition. So get in touch, keep talking, and wish you all the best in the future. Thank you.
Thank you very much, Marco. That was such an insightful presentation. And I think you really shone a light on the extent of undernutrition as a worldwide problem, including those typically high-income countries like the UK and lots of Europe that we don't always associate with hunger. So I personally found that really interesting. Thank you. For our next presentation, I would like to introduce Mr. Mazin Mukhtar and Pragya Chapalali. And they are from the Akshar Foundation, and they're here to deliver their presentation on transforming schools into centres for sustainable development. So if you'd like to share your slides, we're excited to hear what you have to tell us.
Hello, Holly. Thank you so much for having us on here. It's a real pleasure to share our work. At Akshar Foundation, we created a model school in India that's designed to equip children in poverty and from low-income communities to give them the tools they need to escape from poverty and to build a successful life, as well as starting a business and taking care of their local environment. The main obstacle that we encountered when we first started the school was that children were skipping school to engage in manual labor. They were child laborers. They had dropped out of primary schools, so from around age 10, and were engaging in dangerous child labor conditions like construction and stone quarries and things like that. So we devised a program that we called Learning and Earning. We found ways for these child laborers to come to school and to work in the school as they were learning. The students work by teaching the younger kids, as well as recycling plastic, growing food, a wide number of different jobs that they can do to serve their community and generate some income for themselves so they can stay in school. So to give you an idea, I'd like to share a compilation of news clips. These are from the BBC, World Economic Forum, History Channel, Time Magazine, as well as a short speech by the Prime Minister of India, who has also endorsed our model.
I'm so sorry, Mazin, I don't think we can see your screen.
I'm sharing the video now.
Great. Thank you. Sorry.
Can you see that?
Yeah, we can see that.
Okay.
For 25 items of plastic a week, the Akshar School in Guwahati provides its students free and holistic education. A solution that was meant to tackle the abject poverty of children has now built an inspirational model of education fostering sustainability and equality.
भारत और वेस्ट टू वेल्थ की बात आती है तो हमें देश के कोने कोने से अनगिनत उदाहरण देखने को मिलते हैं। असम के कामरूप मेट्रोपॉलिटन डिस्ट्रिक्ट में अक्षर फोरम इस नाम का एक स्कूल बच्चों में सस्टेनेबल डेवलपमेंट की भावना भरने का, संस्कार का एक निरंतर काम कर रहा है। यहाँ पढ़ने वाले विद्यार्थी हर हफ्ते प्लास्टिक वेस्ट जमा करते हैं, जिसका उपयोग इको फ्रेंडली ईंटें और चाबी की चेन जैसे सामान बनाने में होता है। यहाँ स्टूडेंट्स को रिसाइकलिंग और प्लास्टिक वेस्ट से प्रोडक्ट बनाना भी सिखाया जाता है। कम आयु में ही पर्यावरण के प्रति ये जागरूकता इन बच्चों को देश का एक कर्तव्यनिष्ठ नागरिक बनाने में बहुत मदद करेगी।
To a story about a unique school on the outskirts of Guwahati that is bringing in a paradigm shift in how schools are run. Founded by a young couple with the aim to bring children from poverty-stricken families to schools, the Akshar School in Pamohi has not only reduced dropouts and it has helped to stop child labor as well. Here, poor students earn while they learn, and believe it or not, the tuition fee in school is only accepting plastic waste. Here's Ratndeep Chaudhary with a special report.
Akshar Forum School is now mandating that students pay for tuition in plastic waste.
थैंक यू जी, ये रखिए।
ये क्या है?
प्लास्टिक।
प्लास्टिक नहीं चलता, रोकड़ा, मनी मनी।
अरे लेकिन ये तो चलता है।
यहाँ नहीं चलता।
यहाँ नहीं चलता?
बिल्कुल नहीं।
लेकिन आसाम के एक स्कूल में तो चलता है।
क्या?
हाँ, आप OMG मेरा इंडिया देखते हैं?
बिल्कुल।
हाँ, तो चलिए आपको दिखाते हैं कि आसाम के एक स्कूल में इस प्लास्टिक के बदले में बच्चों को क्या मिलता है।
That plastic is recycled by our teenager students to make eco bricks from the plastic, and those eco bricks we use for different kinds of construction. Like we have made a planter at our school. We are also building pathways connecting the classrooms, and in future we want to build a toilet with the eco bricks.
I can say and write what I did this morning.
एक और OMG वाली बात ये है कि यहाँ के बड़े बच्चे छोटे बच्चों को पढ़ाते भी हैं।
Assamese marriage.
The goal was to create a school that would teach the conventional subjects, math, English, science, but combine that with vocational training so that they learn valuable job skills.
जैसे carpentry, embroidery, farming और gardening.
So we've developed this model, and it's been very successful at recovering dropouts and child laborers back into school. We've increased the age at which girls are starting families in the communities that we work in, where it's typical of our students, their mothers had them when they were around 14 or 15. But because we can engage these young girls in school and with these productive jobs, we've been able to postpone their family planning indefinitely so far until they can finish their education. So our main premise is employing these teenagers, these at-risk youths, as agents of change in their communities. They work to teach the younger kids. They work to recycle plastic. They fix furniture. They make clothes. They grow food. All the different needs of the school, the kids are employed to take care of those needs. So now, thanks to the Prime Minister endorsing our model, we're spreading this model throughout government-run schools in India. We're working in 3 states now. The government wants us to spread to thousands of schools. We're, telling them to slow down a little bit because we need some time to scale up. But we've been really happy with the support from the government in helping us to spread. Now we're working with about 1,000 government school teachers to spread our model into these government schools. And we're seeing really great learning outcomes improving. That video, you saw 2 boys working together. Both of those boys are orphans. They don't have support at home. They don't have anyone, educated parents at home who are helping them with their studies. But by employing the older students at low costs, we can ensure that every child gets this one-on-one individual attention. And because of that, we start to see these drastic improvements in literacy and numeracy. So the main premise of our program is we teach the older kids how to teach. By becoming teachers themselves, they become better learners, so their own skills improve. And we bring in experts in different vocations to come and teach the students vocational skills. So we bring in carpenters, electricians, nurses to come and teach actual hands-on skills and to guide the students into careers in different fields. So I'll just take you through quickly a case study of one of these kids who came to us when he was about age 9, was working in a stone quarry, and had dropped out of primary school. He didn't know the alphabet. He could barely add single digits, but because our program treats each child as an individual instead of grouping them by age, we do individual skill assessments of each child and give them the worksheets that they need to build up based on their individual levels. And because of that, he could start to learn the alphabet and learn counting. He could start to teach younger kids, preschoolers, even if he didn't know anything, he could teach them how to hold a pencil. He could teach them how to trace, and he could earn some income from that. But the more he advances in his own learning, the more complex topics that he's teaching, his earnings increase. We say you learn more to earn more. So the more complex topics you're teaching the younger kids, the higher your salary is, and that provides an incentive for them to learn. So if you're teaching algebra, you'll earn more than if you're teaching counting, for instance. Now he's preparing for his board exams. Even though he came to us at age 9 and didn't know anything, he was able to catch up. And he's working in the school, he's teaching, he's recycling plastic, he's growing food. He's transformed from a antisocial young child into a productive and responsible citizen. So this just shows his, we have a precious plastic laboratory in the school, and we're installing these in government schools throughout India, where students can bring in their plastic school fees. We have a requirement for students to, actually, the requirement is for parents to segregate the plastic and send it to school with their children. And the students work to craft new products out of that waste plastic, and they help to sell those products. So it combines education, environment, entrepreneurship, and employability. So as we're scaling up, we've partnered with the University of Oxford to offer an internship program. And one of those interns is here today, Pragna Chalapali. So I'll hand off to her, and she will share her experiences at Akshar Foundation. Let me stop sharing. All right, take it over, Pragna.
Great. Thank you very much, Mazen. Cool. Ooh, sorry. Cool. Hi, everyone. As Mazen mentioned, I'm from the University of Oxford, and I took part in an internship program with the Akshar Foundation, and I really thoroughly enjoyed my time here, and I'm really excited to share what I learned with you all. So I'm not a medical professional. I am from a law background, and I'm really interested in environmental law and how it can be used to make change to the most vulnerable and marginalized communities in society, and pay sustainable development, not just environmental development, but social and economic development as well, which is why spending time at the Akshar Foundation was the perfect way for me to really expand on those interests. So a little overview of my experience. I worked in 2 schools. The first one was a government school that the Akshar Foundation is partnered with, called the RME School, in which Akshar runs summer camps and is slowly trying to integrate their educational model. And secondly, I got the chance to work at the Akshar Forum School itself, which was really incredible, and got to see all of those exciting developments at work. And I taught introductory gardening and environmental awareness classes at the government school, and at the Akshar school I taught some classes on drama, debating and public speaking to try and develop a wide range of skills for students. So I really wanted to talk about some of the links between health and climate change, which has already been discussed so far in this conference, and it's been really interesting to see the ways in which all of those different links have been teased out, but adding in a third dimension, which is education. And I've got this idea of polycentricity on the slide, and polycentric law is when legal structures, such as legal systems, overlap, influence each other, and sometimes compete with each other. But the main idea is that polycentricity allows us to understand that these different legal systems are not isolated entities, but are deeply connected to each other. And I thought that that was a really interesting way for me to understand the links between education, health, and climate change, rather than viewing them as individual entities, viewing them as one part of a larger system that interact with each other and influence each other, and sometimes do compete with each other as well. So I think that's really illustrated in the SDGs themselves, seen by 3.3, promoting mental health and well-being, clear links there with education, and the initiatives that Mazen mentioned to improve mental health and well-being, and 3.9, reducing the deaths from pollution and contamination, some of which has already been discussed so far. I looked at some studies from UNICEF to really explore those links a little further, and some interesting statistics I found on a study by UNICEF investigating how children are disproportionately affected by climate change are the fact that 40 million children are having their education disrupted every year because of disasters exacerbated by climate change, and this number continues to increase, clearly impacting on their mental health and well-being. And I wanted to highlight the impact on girls specifically, and one study from Bangladesh found that the number of marriages of girls aged 11 to 14 increased by 50% in years with heat waves lasting longer than 30 days, which I think really illustrates this idea of polycentricity, and illustrates how climate change, health, and education are social issues as well as scientific issues. Now, to bring the conversation back to the Akshar Foundation, what this organization does is it really addresses the elephant in the room of climate change and sustainability and environmental issues and the role it plays in children's well-being. And instead of highlighting the doom and the gloom, it focuses on how environmental protection and adaptation can actually create opportunities for children, such as the precious plastic workshops or the gardening workshops that Mazen mentioned. And this early report from Alaka Sarma and Mazen illustrates that the students were so much more interested and motivated to learn about the environment, ecology, and their connectedness to nature. And most importantly, they developed a belief in themselves that their actions could impact society and could make change. And especially considering the background that some of these children came from, I'm sure it's a testament to the innovation and the strength of the model that's adopted by the Akshar Foundation. And to really bring into context why a radical shift in education systems is needed, I've got this excerpt from the Annual Status of Education Report in 2022, illustrating that kids' reading and mathematical abilities have been dropping to pre-2012 or 2018 levels. Of course, the disruption to education caused by COVID-19 was probably a huge factor there, but it also illustrates that the strength in education, in traditional forms of education, is not supporting the needs of children fully, and a radical shift really is needed. And that's partly what inspired the National Education Policy of India 2020, which, as Mazen mentioned, is guiding the interactions that Akshar has with government schools across Assam and across India. And it really wanted to shift the educational policies to develop skills needed to thrive in the 21st century, such as creativity, imagination, scientific temper, but also compassion, empathy, and a strong foundation of ethical values. And for me, this creates an obvious link to the climate crisis, because the polycentric nature of climate change necessarily needs students that are able to carry out critical thinking and rational solutions to climate change problems, but are also able to show their compassion and empathy to understand how those solutions can shape a more equitable world for everyone. So with all of these very interesting and profound ideas, I tried my best to implement those ideas. And I started off with the gardening classes at the government schools. And as Mazen mentioned, these schools are slowly trying to integrate the Akshar philosophy. They're not quite there yet. I think this particular school is a phase 2 school. So it's implemented some of the literacy and numeracy changes, so assessing children by their own stages of development rather than trying to move all kids together, and elements of plastic recycling. So I carried out lessons in gardening, such as like seed germination, composting, teaching kids to identify local plant species, as well as general environmental awareness, such as renewable energies, and actually introduced a lot of young children to the idea of climate change, because I was working with kids aged around 5 or 6 up to ages 12 or 13. And it was really great to see the effects that vocational training had on these kids. I saw a lot of increased confidence, not only within the vocational training itself, but it spilled over into other areas. They had to show a lot of perseverance and creativity in activities such as building their own model turbines or figuring out what conditions would be the best for germinating their plants, and it's creative problem-solving muscles that they don't necessarily get to exercise a lot in their traditional schoolwork, and it made them more enthusiastic for learning more generally. But central to that, as Mazen said, is the idea of peer learning, and they really enjoyed working together to solve these problems. And in the Akshar school itself, I enjoyed delivering some drama, debating, and public speaking classes with some other interns. And given the background of the kids that attend the Akshar school, there were quite a few initial difficulties, such as confidence issues, issues in self-expression, whether it was written or verbal, and difficulties in developing their ideas with nuance. But I really wanted to do my best to try and increase their confidence and feel confident to develop their own ideas and express themselves. One really surprising thing was that I asked them to pick any topic of their choosing, and they all naturally gravitated towards picking environmental issues, which I guess really goes to show the extent to which environmental awareness is really integrated into the curriculum at the Akshar Forum. So topics such as, why is health and hygiene important to us as kids? Are zoos good or bad? How can we end plastic pollution? Should we ban cars? And those were ideas that the kids had come up with themselves. And I really enjoyed developing those ideas with them and trying to build their confidence. And this was a project that had a lot of success because at the start, kids that were really struggling to express themselves managed to deliver speeches to their peers, which is what you can see in the pictures there. And they, again, there was a lot of emphasis on peer learning and seeing older kids helping the younger kids to develop their ideas. And when we think about the changes in curriculum that the Akshar Foundation is trying to implement, I found this interesting study in which data was collected from COP participants, and they found that one of the biggest issues was communication and developing the mindset for climate action, and that participants found that there was a need for a mindset shift to support new ways of communication and collaboration. And I think that that's exactly the kind of mindset shift that Akshar is trying to cultivate in kids right from a really early stage. And even though I'm sure that the data from this study isn't infallible, it really illustrates that at the highest level of decision-making, environmental decision-making, there is a cultural problem and a communication problem rather than a scientific or technical problem, which is something I found really interesting and really enjoyed tying back to the national education policy and the Akshar model. So to tie everything together, I wanted to have a little look at a case study from Assam, which is the flooding that is so frequent in Assam every year. And that top picture is actually a picture that I took one commute to school. So flooding is quite common in Assam because of its proximity to the Brahmaputra River, but it is worsening every year due to human activity such as deforestation, but also climate change. And those statistics on the screen there show just how grave the problem is and how much it's affecting the population of Assam. And I thought this was a really interesting intersection in climate change, health, and development because children are obviously very affected by this yearly flooding because they are forced to miss school every year, not only due to school becoming inaccessible, but in rural areas. And I had the opportunity to visit a few rural schools that Akshar works with. I heard that schools were often turned into makeshift flood relief centres, sometimes for weeks or months on end. And this is especially important considering that around 85% of Assam's population does live in rural areas. The missing the school was something I saw firsthand as well. During the monsoon season, student populations would really fluctuate, and sometimes teachers were unable to come to school as well. And the really interesting thing was that I actually did struggle to find any concrete statistics on just how many kids miss school per year due to flooding in Assam. And I think when we think about the importance of relational information and first-hand anecdotal information and how it influences climate policy and educational policy, I thought this was a really interesting case study, and it shows how even how all experiences really need to be taken into account when making really robust policies to help child health policies and educational policies as well. And I've highlighted some of the effects, long and short-term effects of this flooding on kids' health and education in Assam. So that's all from me today. Thank you very much, ICHG, for allowing me to be part of your event. I've really enjoyed it, and thanks also to Mazen for letting me represent your fantastic organization. Thank you.
A big thank you then to Mazen and Pregna. It was really inspiring to see your presentation, and particularly your video. I think that really showed the transformative impact that the Akshar schools have had on the children who attend them. So that was brilliant to see. Thank you. I'm now going to hand over to Dr. Anya Sasso, and she's going to be hosting the Q&A for our brilliant speakers.
Thank you, Holly. And just to echo Holly's sentiments, thank you so much again to our brilliant speakers. Really a lot of food for thought, and I know a lot of questions in the chat. And so I'm just going to kick off before we run out of time. So I think the first kind of broad question to Marco would be, how big a role do you think food regulators and also marketing play in undermining our goal to achieve zero hunger? So be that with exclusive breastfeeding, for example, in nations where formula is so heavily marketed and available. And I know Helen had a question in the chat about what can we learn from the global south, or I guess marketing of unhealthy or ultra processed foods, especially among children.
I think that's a great question. And if you haven't read up on it, I mean, I'm sure many people here are familiar, but there's a really growing and really important area of work, the commercial determinants of health. And just recently, there was an event, I think at the Royal Society of Medicine, so co-hosted by the WHO, Nigel Rowlands being one of the many actors in that, who did a big Lancet series on commercial determinants of health as it applies to breastfeeding. But I think that's a really growing role. And I think it's one of those complex things that industry actually has a huge role to play, but industry also reacts to what people want. And so it's about, I think, this audience being part of the drivers, changing demand, trying to increase political pressure for action to be taken. That, what I've just come back from a meeting in Serbia, and people there in the nutrition world were reflecting on things being very, very behind because they're just not the same civil society, not the same engagement. So food companies in other settings find it a lot easier just to do whatever they want. So I think there's lots of positive things being done in the UK, positive things being done in many countries, but it is about keeping things high in the advocacy agenda, pressuring governments, I think engaging with the political process. And I think for me is one of the biggest things. It's about understanding the local, the national, and also the international political process and trying to influence at key steps of that. So yeah, food industry and regulators have a huge role to play.
And how, I guess following up on that though, how do you think as healthcare professionals we can actually lobby, I guess, industry directly or authorities? How do we actually, I mean, do you have any tips on how we actually go about?
Yes. I think it's important to realize it's a completely different skill set and different group. So I think engage with advocacy groups and who do this on a regular level. I mean, I've just come back from another meeting organized by the Eleanor Crook Foundation, who are one of our funders, but who are very, very active in the global advocacy space. And they would, for example, or they and their colleagues in their networks would have regular meetings, regular briefings with politicians, would organize visits for politicians to go and see projects. And I think that's the kind of thing I think we should be learning from that process and figuring out how to influence, how to impact. Again, at another conference, I recently met some really inspiring advocates working in patient organizations. And the thing that they do, for example, they find out, they Google, they do lots of exploration about which MPs have been, for example, personally affected by an issue and target those for initial conversations, target those to ask questions in Parliament, target those to get a debate set up. So I think it's about learning from the advocacy world and being a lot more in touch with the advocacy world, because sadly, I think few policymakers look at the evidence as we do. So the evidence is helpful, but is secondary. It's about those personal engagements, understanding how the system works. And I think regarding another excellent question that Prof. Andrew Tompkins, great to see Andrew, was my PhD supervisor and really inspired me in this field, was about what can we do to inspire politicians to act. And I think what we also need to do is articulate also how it's in their interest. So how it would benefit them, how it would benefit local societies. And when they take action, I think on food, on nutrition, on standards, etc., how is it going to be a vote winner for them? And I think that there's lots and lots of benefits, but we need to be very clear and articulate them.
Yeah. And just for those of you who are new to ICHG, we do have a very active and inspiring, I would say, advocacy stream. So please do join us. And also, Marco, thank you for all your links that you've put there. We're going to try and collate them and share with our members as well after the meeting. And just, I guess, one more question again from Andrew Tompkins was, what would your advice be to FCDO to improve nutrition in low middle income countries most effectively? Just a simple question.
Yeah, I think to articulate why it's also important for the UK in terms of lots of issues are actually quite common in low-income humanitarian settings and now sadly becoming common in the UK. We've just got a PhD student started who's looking at infant young child feeding in emergencies in a UK context, because we realise there's actually not a clear policy about what to do in floods, in displacements, etc. in the UK. So I think, again, it's articulating those common links and how what we can do in terms of outreach, in terms of global work, can also be of benefit in the UK. Again, I think everybody here, I'm sure, does it because it's the right thing to do. There are lots of politicians who also believe it's the right thing to do, but they need to articulate to their constituents, to others who are not so convinced about the wider benefits to the UK. And, one of the things that we've been also saying is that it actually, I think UK has been a traditional leader here and has done lots of great work historically. So we need to build on that. And it benefits UK research, UK development. So I think it's looking for those common wins and really promoting them and emphasizing those.
Thank you, Marco. And just to move on to the actual foundation. So again, a big thank you and an inspiring talk as well. And you can see from the comments that the audience has really enjoyed listening and hearing about your fantastic initiative. So with regards to some questions, so one of the first questions on there is about the funding for the foundation, particularly to provide the salaries for the children. If you could, one of you could comment on that, perhaps.
So we're funded by a number of private foundations and corporate social responsibility. So India has a requirement for corporates that are big enough to devote 2% of their profits to funding philanthropy. So that's been a big source of funding for us. But we have to dedicate a portion of our funding that may, usually have been spent on hiring a teacher, for instance. We spend the equivalent of the salary of one teacher and distribute that amongst the teenage teachers. But the benefit of that is that each of our young students gets daily one-on-one individual attention. So we found that to be a very worthwhile trade. It's also a common problem throughout India and throughout the developing world, where teacher absenteeism is a big problem. Teachers are not showing up for school in many cases. So by employing the older students as tutors, even when the teacher is absent, we've seen this in our school and in government schools, the students automatically come in, collect their schoolwork, and start teaching the younger kids. It's just become an automated system. So we can use this model, this learning and earning model, to create autonomous learning communities that can run even in the absence of teachers.
Wow. That's very, very impressive. Really, congratulations on your work. And again, a comment and a question from Tony Waterson. Remarkable vision being shown by the foundation, and recalls for me the Brigade's school in Botswana started in the 80s and still in operation. And I wondered if there is opposition to the concept from traditional society, and also if there is a special teacher training program, which you sort of mentioned, as the skills required are much broader than in conventional schools. And I guess similar to Tony's questions, Holly asks again about the community uptake. But I also know from what you said, and also reading from your site, that it is based on a traditional holistic model as well. So that's quite an, I guess, building on what's was there already. But yeah, if one of you could address those questions. Lakshmi.
Yeah, I think that what was really surprising to me when I interned there was the fact that actually there wasn't as much opposition as I might have expected, because it's giving parents an incentive to keep their kids in school because they are earning while they're learning. So instead of kids being economic burdens, they're now, I guess, economic assets. So that's one reason why there hasn't been as much community pushback as you might expect. Another is that despite the vocational training, Akshar still does put a lot of emphasis on traditional literacy and numeracy. And in my experience, the numeracy at the Akshar school was a lot higher than literacy and numeracy at the Akshar school was a lot higher than at the government schools, because I think there's so much more motivation to learn. And I think the peer learning and the one-on-one learning really does help keep kids motivated and does produce better results. And also the philosophy of letting kids go at their own pace means that some of the negative feelings of feeling inadequate compared to your peers or not doing well enough, Akshar has managed to tackle some of those feelings. I think one area of pushback, I remember speaking to Mira, who I think is a regional lead in Assam. Akshar really likes to try and push boundaries, and one area they've done that is period awareness and period poverty awareness. And that is one area in which there has been a bit of resistance, and parents have been slightly less keen to engage, but Akshar is persevering, and from my understanding, they host workshops every so often, asking girls and parents as well to come in to deliver like period awareness and period poverty awareness. And it's getting better, but that is one area of pushback that the school has faced.
Thank you. And I think we're almost about to run out of time. So I'd just like to say a big thank you to our speakers again, and congratulations on your work, and also best of luck with the work. And I'm sure you'll have inspired a lot of people on this meeting today. And I'm sure you'll get a lot of follow-up emails and questions. So thank you again. Just to everyone else listening. So so now it's time for our lunch, but we also would like to, for those of you who are interested, share a video from Professor Naveen Thakur, who was due to present earlier but unfortunately couldn't make it, but has sent us a video. So Professor Naveen Thakur is the director of the Deep Children Hospital and Research Centre in Gujarat, India, and he's also the president of the International Pediatric Association, or was the president for, and it continues to be the president in the last 2 years. And his talk will be on the role of pediatric societies in achieving the SDGs. So you're very welcome to stay and listen to the talk, but please do also feel free to grab some lunch as well. And we will see you back at 1:45 for the third keynote speech. Thank you, everyone. I'm not sure we can hear that. Just trying to sort out volume issues. Okay, we're going to just reshare again so that we can hopefully hear the talk. And yes, please do grab a snack, a drink, and have a listen. And we'll also, as I said, see you back here at 1:45. Thank you, Helen. Okay, in view of the technical issues, we're going to just sort them out, and then we're going to play the video just before the next session. We're going to attempt to play the video just before the next session starts. So if you can rejoin at 1:35, we will play the video then, hopefully if we've got the volume sorted. But enjoy your break until then. And please do also join our networking sessions by pressing the breakout session button on the left-hand side of the screen.